Chat accordingly. Hmm. Okay.
Hello everyone. Am I audible? Hello everyone. Am I audible? Hello everyone. Am I audible? Hello everyone. Am I audible?
Yes. Hello, everyone. A very good evening. Yes. Good evening, Thunderbolt. Good evening, Thunderbolt. Good evening, Sanchita. Good evening, Shweta. A very, very happy good evening to one and all. And this is Priyadarshini. I'm here for your NORCET main series. Right? Yes.
Good evening, Thunderbolt. Good evening, Thunderbolt. Good evening, Sanchita. Good evening, Shweta. A very, very happy good evening to one and all. And this is Priyadarshini. I'm here for your NORCET main series. Right? Yes. Good evening.
The title. Yes. A very good evening. I hope I'm audible now. Everything is clear. Yes. So I welcome you all to the NORCET main CBQ discussion, which is going to be completely in English, as you all know. And my hearty congratulations for the students who have got selected in your prelims. And for the students who have not selected, and this is not a destiny examination, we have many other examinations which is going to come on, right? So definitely, this is not a decider. So whatever you feel, whatever doubts you have, you can put in the comment box. I will be answering for you. Very good evening, Suman. Very good evening, Snudi. Okay. So here in this series, in this particular session, we are going to completely discuss about the clinical based MCQs, right? To be very clear, it is completely a clinical based MCQs. And here it is not only about solving the MCQs, you're going to learn how to approach a clinical based MCQ. Like a point in a point of a nurse, how a safe nurse will take an action at that particular point. Everything you will be learning in this video. So be with me till the end. So let's get into the session. The first MCQ which you're going to see, and I want you to actively put the answer in the chat box, not only the answer, along with it minimal rational, and you can also put the important key points which can be possibly asked in the NORCET examination. The first question for you people is: a 65 years old male present to the emergency department with rapid deep breathing, nausea, and altered sensorium. His atrial blood gas analysis reveals the pH is 7.25, the PCO2 is 28 mm of Hg, and the HCO3 is 15 milliequivalent per liter of your PaO2. That is your 92 mm of Hg. And which of the following is the most appropriate ABG interpretation? Which of the which is the proper ABG interpretation? Now I want you to answer for this MCQ. Is now it is very clear? Yes. Yes. Now answer me. Yes. So all the students who have attended the ABG sessions will be very clear like how to answer this question so tactically, right? If you talk about the pH is 7.25. The normal pH is 7.35 to 7.45, right? The pH is reducing here. Then what about the normal PaCO2? The normal PaCO2 is your 35 to 45, right? Your normal PaCO2 is 35 to 45. So here, if you see the PaCO2 level, it is 28, which is showing it is also declining drastically. So the primary rule which I taught to you people, is when pH and PCO2 are going in same direction, what is the problem? If pH and PCO2 is going in same direction, the problem is metabolic. So what I said, you have to think about the metabolic problem. And based upon the pH, you will be deciding either it is acidosis or alkalosis, right? If pH and PCO2 are going in reverse direction, then the problem is respiratory. That also I taught you. You have to remember the same M for metabolic, reverse R for respiratory. So if you see here, the pH is also declining and the PaCO2 is also declining. We are clearly defining the problem as the metabolic problem. So everything is going in same direction. With the help of the pH, we are deciding it is an acidosis. So we are coming to the conclusion it is a metabolic acidosis with respiratory compensation which is happening, right? So let's go to the next question. So before going to the next question, I would like to discuss certain important things. Always remember about the base component and acid component, right? So what are all the acid component? The acid component or your PaCO2. For example, your carbon dioxide is an acid component because it is stored inside your blood as your carbonic acid, right? So that is the acid component. And your hydrogen is also a acid component. What is a base component? The base component is your bicarb. Your HCO3 is the base component. This is again a very, very important point to note. Now tell me in the chat box if the patient is having hyperventilation, what will be the ABG finding? If the patient is a case of hyperventilation, right? If the patient is on hyperventilation, now tell me what will be. Yes. What will be the finding? What? Yes, very good. Some students are answering. Yes, Shruti. Yes. So what is happening when I'm doing hyperventilation? I'm doing a lot of inhalation and exhalation. What will happen if a patient is doing hyperventilation? I'm doing rapid respiration. What will happen? There will be CO2 washout. There will be CO2 washout. What does mean by CO2 washout? I am rapidly inhaling and exhaling all the carbon dioxide and making a CO2 washout. What it means? CO2 is an acid component. If CO2 is getting lost, the patient will go for if the patient will go for respiratory alkalosis, the patient will be going for respiratory alkalosis. Why? Because of this? Because there is an acid component washout, that is your CO2. If the patient is going for hypoventilation, what is going to happen? The CO2 will be so much accumulated. CO2 accumulation will be there. So what is going to happen if CO2 accumulation is there? The patient will be going for respiratory acidosis. Which means excessive carbon dioxide is accumulated inside my body. So my body is going for respiratory acidosis. This is very, very important to note. When we talk about this bicarb, HCO3, right? When you talk about this bicarb is completely excreted and evaluated and monitored by your kidney, right? Whether your PaCO2 is monitored by your respiratory system. That is very, very important to note. Let's go to the next question. A client with end-stage renal disease, oxygen-dependent COPD, right? And a do not resuscitate order is admitted with COPD exacerbation, right? The nurse finds the client not breathing, and what should the nurse do first? Now answer me. in a clinical perspective, the client is a case of end stage renal disease, and she is an oxygen dependent COPD patient. Now he is in the order of do not resuscitate and admitted with COPD exacerbation, right? The nurse finds the client is not breathing. What should the nurse do first? Yes, I want your answers. I want your answers. A patient is on do not resuscitation order. What you will do? He is not breathing. What will the nurse do next or first? Answer classically and tell. Yes. Shnidhi, Neha, Suman, very good. You have to check the apical pulse, right? So the primary action, what you have to do is, since the patient is on do not resuscitation, we are not going to do any form of intervention to the patient. We are going to confirm whether the patient is declining or not. What we have to do, once the breathing is not observed, any form of active respiration is not attained by the patient, next we have to check the apical pulse to confirm the patient is declining. Without checking the apical pulse, you're not supposed to inform to the healthcare professional. It is not mandatory. You're provoking unknown effects, right? If you're confirming the apical pulse is also absent, then you're going to tell that it's going to be the declining process and you're going to inform the healthcare professional. The first action which you're going to do is what? Checking for the apical pulse. Activate code system, no, because the patient is on DNR. And once you are monitoring the apical pulse, then you will be going for informing the healthcare provider. Checking for blood pressure will not be the correct answer. So the next question. Yes. So a client has sustained a traumatic brain injury secondary to a motor vehicle accident. With signs and symptoms, which signs or symptoms would the emergency department nurse expect the client to be exhibiting? Now tell me, as a nurse, what kind of signs and symptoms you expect from a patient with a traumatic brain injury? Yes, I'm waiting for your answers. B. Students are answering B. Yes, thunderbolt. See, children, they are generally asking traumatic brain injury. If the patient is a case of traumatic brain injury, what will be the signs and symptoms? Some students have answered correctly. Yes, A is the correct answer. The patient will be experiencing blurred vision, nausea, and right side hemiparesis. Right. Though the side is not specific, but when we talk about the urine output and all these things, increased urine output is not associated with your traumatic brain injury. And negative Babinski sign. Negative Babinski sign is normal in adults. Right? And ptosis. In not all the cases, you will be seeing ptosis. What about this autonomic dysreflexia? Now tell me, what is autonomic dysreflexia? This happens when there is a spinal cord injury. When there is a spinal cord injury. And what about this positive Brudinsky sign? Positive Brudinsky sign is seen in case of your meningitis. And hyperreflexia. This occurs in brain injury. Right? So negative dextrostick. What is meant by your dextrostick? Dextrostick is nothing but your CBG monitoring. That is your capillary blood glucose monitoring. So that is your negative dextrostick. And knuckle rigidity also is seen in case of your meningitis, and nystagmus is also seen in case of your brain injury. But all the three components, which includes your blood division, nausea, and right side hemiparesis. What is blood division is indicating? It is indicating some cranial nerve damage. Okay, it is involving either the cranial nerve damage or the increased ICP. What about nausea? That nausea is the primary sign that the patient is having an increased ICP. Right side hemiparesis due to a transient ischemic attack. Right, the patient will have a weakness to that particular side. Focal weakness. So that's why this A is the correct answer. See, you have to see and watch each and every word so clearly, right? So that whether it is suiting to the answer or not. When you have this three components in an options, all three components should satisfy the question. If one component is negative also, that is a distractor. You should be very clear in that. Now let's go to the next question. A client is admitted to the ICU experiencing status epilepticus, and which intervention should the nurse anticipate implementing first? Right? I am here stressing you the first letter, okay, the first word and all. In examination, you should be very clear how you have to stress this first and all. Right? Now tell me the answers. A client is admitted in the ICU experiencing status epilepticus. Which intervention should the nurse anticipate or implement first? Now I'm waiting for your answers. Yes, the active students, kindly answer. The one who are ready for the rage for your mains, answer me. Assess, some students are answering A. See, clinical questions. That's why I have put clinical questions to confuse you all. Many of the students are answering A. See, status epilepticus is a life-threatening condition. Okay, it is a life-threatening emergency. Right. At that case, only you will be doing assessment. At that case, only you will be doing the assessment. Tell me. It is a life-threatening emergency. At that time, you will be doing only the assessment. Now also you can change your answers. Yes, very good. Very good. See, initially, seeing the question superficially, seeing the options superficially, you're going to answer it wrongly. Be very clear what they're actually expecting. Right? So what you have to do, if the patient is on life-threatening emergency, status epilepticus is a life-threatening emergency. This, if you're not treating it properly, it is going to prolong the seizure. It is going to prolong your seizure. And what is going to happen? At last, it's going to cause hypoxia and severe brain damage. Right? So what you have to do? Yes, here intervention is very important. Thunderbolt, very good. What is your good name, dear? Please tell your good name, Thunderbolt. See, here the intervention is very important when comparing to the assessment. So you should classically able to differentiate. If the patient is going to die, at that time also assessment is not important. At that time, intervention is important. This is very, very important point to note. So what happened? You have to administer diazepam, a benzodiazepine drug, to reverse the seizure and to stabilize the patient and preventing the patient from going for hypoxia or any form of severe brain damage or death. Right? So if the patient is going for near death, you should be very clear that intervention is more important rather than assessment. Later, you will be doing, once the patient is stabilized, after giving benzodiazepine, the seizure is reverted and the patient is stabilized, then you're going to assess for the client's neurological status and everything. And monitor the client heart rhythm via telemetry, which is none away, which is coinciding with the question. Prepare to administer anticonvulsant medication. Always remember, anticonvulsant medications are for maintenance. Right? Once the patient is reverted from the seizure, you are maintaining the patient with the help of the anticonvulsant medication. Right? So first is administering benzodiazepine. See, here they are asking implementing first. What does the nurse anticipate implementing? So remember, there is always NORCET examinations and competitive examination will play with the words. Here they are asking, what is the anticipated implementing? Right? What the nurse is expected to do first. Right? Rather than doing an initial assessment, rather than doing all these things, the primary responsibility of a nursing person is to save the life of the patient. You have to think in that aspect only. Understand the question and you have to answer. What I'm anticipating, it is not like you are directly administrating. What is anticipated? What I am expected to do in that particular situation? What I will do first, right? That is how you have to classically differentiate the question. Right, dear children? You have a clarity now? See, anticonvulsant medications such as your phenytoin, phosphophenytoin, these are all given for your maintenance therapy for a seizure patient, right? This is also very, very important. So the next question. A client diagnosed with chronic atrial fibrillation has experienced a transient ischemic attack, right? TIA stands for your transient ischemic attack. Which discharge instruction should the nurse implement? Right? What is the primary discharge advice you give for the patient? Yes. Now tell me. A client is diagnosed with atrial fibrillation, has experiencing a transient ischemic attack. Which discharge instruction should the nurse implement first? Yes, I'm waiting for your answers. Yes. Very good. So here you people are very clear, like once the patient is a case of atrial fibrillation, he's at the high risk of going for thromboembolization, right? Thromboembolization. So it is very, 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 very important. It is very, 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 very important that the patient will be going for warfarin therapy, right? So a case of atrial fibrillation, high risk for thromboembolism, and the important drug of choice is warfarin. So obviously, the important drug monitoring which you have to do when the patient is taking warfarin is your INR. Now tell me superbly, like what is the therapeutic level and the normal level of your warfarin? Now tell me, what is the therapeutic and normal level of your warfarin? Keep the nitroglycerin tablet in the dark color bottle. Someone is answering that this is the correct answer. No, dear children. See, your NTG tablet has to be kept in the dark colored bottle because the potency of the drug is affected when it is kept in the sun exposure, right? But NTG is given in case of angina, right? NTG is given in case of angina, right? You have to correlate atrial fibrillation. The patient will be going for thromboembolism. Okay, and the patient is having a transient ischemic attack. What is meant by transient ischemic attack? What is meant by transient ischemic attack? Very good, Sanjita. Right? The therapeutic monitoring of your warfarin. Like when the patient is on a warfarin therapy, the therapeutic level will be 2 to 3. Right? So now tell me, like in case of angina only, the patient will be getting nitroglycerin. That is very clear. Now coming back to transient ischemic attack, you have to tell me what is transient ischemic attack. Transient ischemic attack is a sudden form of ischemia which is happening in your brain. But you have to remember, whenever there is a transient ischemic attack, there is no infraction. There is no infraction. And this is a reversible condition. This is a reversible condition. Reversible condition. Transient ischemic attack means there is a sudden loss of oxygenation to the cerebral tissue. And very good, very good, very good. The patient will be reverted within 24 hours. It is reversible. And the most important key point you have to remember is the patient will not be having any form of infraction. Here, there is no any form of cell death or nothing will be there. But a sudden loss of oxygenation to the cerebral tissue will be there. Okay? For a short time, the patient will be having this effects and having the signs and symptoms, right? So taking over-the-counter vitamin K tablets daily, that is strictly contraindicated for the patient. Check the radial pulse period to all medications. It is also not relevant. Now tell me an ECG question now. Which medication should the nurse prepare to administer for a client exhibiting the following telemetry strip? Yes, I'm waiting for your answers. Mini stroke. We can tell it mini stroke, but the most important thing you people have to remember is there will be no infraction. In stroke, there will be infraction, brain damage. It is irreversible, but this is reversible. Now tell me what is the answer? Sudden speed. I want quite speed. Which medication should the nurse prepare to administer the client exhibiting the following telemetry step? Yes. People are answering adenosine. See, what is the ECG? What is the ECG is telling? ECG, first interpret the ECG. I want you people to interpret the ECG. Yes, please give a big round of applause to Nagaraj. Lidocaine is the correct answer. It is not adenosine. See, first interpret the ECG. Now tell me what is the ECG? Polymorphic ventricular tachycardia. No, it is a multifocal. It is a multifocal PVC, premature ventricular contractions. You can see the PVCs. You can see the PVCs here, which is very multifocal, which is not following same pattern also, which is very multifocal, which is very ununiform, right? So this is a case of a PVC where the patient will be having a wide, bizarre QRS, a wide, bizarre QRS. And the most important thing is, which is occurring in different shapes. The QRS will be occurring in different shapes. And what about the P wave in this case? Now answer me, what about the P wave in this case? There will be no preceding P waves. No preceding P waves. This is very, very important. This is a case of PVC. For PVC, the important management is administration of your lidocaine. It is a dangerous rhythm. Lidocaine is a class 1B drug. It is a sodium channel blocker, right? It is a sodium channel blocker. Okay. So digoxin, which you are giving in case of your heart failure, right? Digoxin is given in case of your atrial fibrillation, which is accompanied with your heart failure. Adenosine is a drug of choice in case of your supraventricular tachycardia, any form of ventricular abnormalities or ventricular dysrhythmias, you're going for adenosine. Lidocaine, you're administering for premature ventricular tachycardias. Digoxin, atrial fibrillation accompanied with heart failure. Your dopamine is a positive inotropic drug, which is given in case of shock and hypotension. So let's I will show you the other form of premature ventricular contractions as well. See, premature ventricular contractions means what? Which means before an actual proper ventricular contraction with the excitation, it is happening prematurely. That is your premature ventricular contraction. So here you can see bigeminy. What is meant by bigeminy? For every second normal wave. For example, this is a normal PQRS, and here you can see the what? You can see the premature ventricular rhythm. And again, this is the normal QRS, and again you are seeing a premature ventricular rhythm, the second wave. Every second wave will be having a premature ventricular contraction, right? Every second wave will be having a premature ventricular contraction that is termed as your bigeminy. Remember, ventricular bigeminy is very common in which drug ingestion? Ventricular bigeminy. Your ventricular bigeminy. Your ventricular bigeminy is an important rhythm, a most common dysrhythmia which is happening with digoxin toxicity, which happens with digoxin toxicity. Remember, an important MCQ. So next we are going to talk about trigeminal. Trigeminal means what? Bigeminal is every second wave. Trigeminal is every third wave will be a premature ventricular contraction. Every third wave, you will be projecting a premature ventricular contraction. So multiform, and I said uniform and multiform, right? So as we seen, the previous ECG was what? Yes, very good, Suman, very good. The previous ECG was exhibiting what? It is exhibiting the multifocal, right? Which means there is no synchrony at all. You can find here it is upside down, it is straight, like that. You can find the premature ventricular contraction, which is so ununiform. So next we have this premature ventricular contraction, which is couplet. See, you can see 2 premature ventricular contractions, which you can see in the similar form within the same cycle. Like first cycle will be having PVC, the next cycle will also have the PVC, then a regular rhythm, then a regular rhythm, then again a PVC and a PVC, then a regular rhythm. So this is your premature ventricular contraction couplet, right? So we will go to the next question. The client is first day post-operative open heart surgery, has a temperature of 99 degrees Fahrenheit, a pulse of 96, a respiratory rate of 22, and the BP is 128 out of 92. And is complaining of incisional pain of 8 out of 10 pain scale. What intervention should the nurse implement? Classically, think like a nurse. What is the priority action? Seeing all these things, a post-operative patient with post-CABG, open heart surgery, which is indicating the patient is a case of CABG, the CABG patient who is having the pain 8 out of 10, and the following respiratory, temperature, and all the parameters are given, what is the important intervention you will be doing? Yes, answer in the chat box. Yes. Very good. So now you have classically, you started seeing the MCQs and you started classically think like a nurse, right? So if the pain score is going to be 8, a post cardiac surgery patient, this is going to stress the patient. And it is very, very important. If the patient is not treated for this pain, he's going to increase his heart rate, the blood pressure is going to increase, the myocardial, the BP is going to increase, the heart rate is going to increase, the myocardial oxygen demand, O2 demand is also going to increase, which is going to cause severe form of complications to the patient. So it is very, very important to administer narcotic analgesics to this particular client. Practical implication is very important, children. Whatever the examination, either it is NCLEX, either it is NORCET, the practical implication is very, very important. Right? Yes. So continue to monitor the client and take no action. No, always remember, whenever there is a word no action, it is not at all the answer. No action is not at all the answer. Administer antipyretic acetaminophen. It is not effective for a patient with CABG pain, and the pain level is also so much high. Assess the client for pulse oximetry reading, which is not at all a mandatory finding. Now tell me, a nurse reviews the electrolyte results of a client with a chronic kidney disease and notes the potassium is 5.7 milliequivalent per liter, right? Which pattern should the nurse watch for the cardiac monitor as a result of this laboratory value? Simply, it is a direct question, which is stating a patient is a case of hyperkalemia. What are all the ECG findings you'll be seeing? A patient is a case of hyperkalemia. What are all the ECG findings you'll be seeing? Now select all that apply. It's a select all that apply question. Yes. Answer me. Just give the numbers. No, it is a select all that apply question. Very good, Sanjita. Please give a big round of applause to Sanjita. It is your 3 and 5. Along with 3 and 5, what are all the other things the patient with hyperkalemia will be processing? Here you can see the normal potassium level is 3.525 milliequivalent per liter. Okay, normal potassium. Here the patient is experiencing 5.7, which is a hyperkalemia. Yes, very good, very good, very good. 3 and 5, very good, very good. Yes, all set. Now only you people are on the pace. Very good. Citizen, along with tall peaked T wave and a wide QRS complex, the patient will be having other ECG findings also in hyperkalemia. I'm asking to list out those findings as well. The other findings are your prolonged PR interval. Your prolonged PR interval. Yes, your prolonged PR interval or flattened or absent P wave. Absent P wave. These are all the findings you can see. So in ST depression is seen in case of which condition? It is seen in case of your hypokalemia. ST depression is seen in case of hypokalemia. Prominent U wave is also seen in case of your hypokalemia. Right? And prolonged ST segment is seen in which condition? Prolonged ST segment is seen in which condition? Prolonged ST, very good, very good, very good. Trisotra, very good. Prolonged ST segment is seen in which condition? Prolonged ST segment is seen in case of your hypocalcemia. Right? So tall peaked T wave, wide QRS complex, along with prolonged PR interval or flattened P wave. If they were in the options, they are also correct. These are all the findings which are seen in case of your hyperkalemia. In hypokalemia, you see ST depression, prominent U wave, and prolonged ST segment, which is given in the option. That is seen in case of hypocalcemia. I have compiled an easy table for you to memorize these things before going for examination because this is very, very important part, right? So electrolyte imbalances, hypokalemia, ST segment depression, shallow, flat or inverted T wave and prominent U wave. Hyperkalemia, just now we have discussed tall peaked T wave, flattened or absent P wave, widened QRS and prolonged PR interval. Hypocalcemia, prolonged ST segment, prolonged QT interval. Hypercalcemia, what you can see, shortened ST segment, wide T wave, and the patient will go for heart block, which is a problem in the complete conduction delay. Hypomagnesemia, tall T wave and depressed ST segment. Hypermagnesemia, prolonged PR interval and wide QRS complex. Right? So you can see magnesium and potassium are quite friends. Right? Magnesium and potassium are friends. So you can see, like compare both and read so that you can memorize it very easily. For example, in hypermagnesemia, you see prolonged PR interval and widened QRS complex. Same way, in hyperkalemia, you can see widened QRS complex and prolonged PR interval. Likewise, you have to match the common terminologies and you have to read so that it will be very effective. If you want, you can also take a screenshot of this. Yes. The nurse reviews a client laboratory report and notes that the client's serum phosphorus level is 1.8 milligram per DL. Which condition is most likely cause this serum phosphorus level? A direct clinical MCQ. Please answer in the chat box. A direct clinical MCQ. A patient is having a phosphate level of 1.8. First, comment the normal phosphorus level. The normal phosphorus level is, yes, comment me, what is the normal phosphorus level? 3.0 to 4.5 mg per DL. Right. So obviously the patient is going for 1.8, that is hypophosphatemia. Right. Now tell me, what is the cause of hypophosphatemia? What is the most likely cause? Many students are answering C. C, be so tactical. What is the correct answer? C is not the correct answer, dear children. C is not the correct answer. See, primarily when we talk about phosphate, hypophosphatemia occurs when the patient is on starvation. Causes. Very good. A is the correct answer. Dikshita Sharma. Please give her a big round of applause. Starvation. Malnutrition. Starvation, malnutrition, chronic alcoholism. Again, tell me what are all the causes? You can see hypophosphatemia. Refeeding syndrome. This is very, 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 very important high yield point you have to remember while studying for your NORCET competitive examination. In case of refeeding syndrome, for longer period, the patient is not having a proper nutrition. Suddenly you are feeding the patient with good number of or more number of nutritious parental nutrition. At that time, the patient will go for refeeding syndrome, right? The most important electrolyte imbalance the patient will get is phosphorus or phosphate, right? This is very, very important to note, right? Very good, very good, very good, very good, very good, very good, right? So in case of respiratory alkalosis also, in case of respiratory alkalosis, also you can find the patient is going for hypophosphatemia, right? So malnutrition will be the correct answer. Then what about this renal insufficiency? In renal insufficiency, the patient will be going for increased phosphorus level only, not decreased. Because the renal tissue is impaired, the kidney is failure, the phosphate excretion is not possible. The patient will be going for hyperphosphatemia. If you talk about hypoparathyroidism, what will happen? Either hypo or hyper. Yes, tell me. In case of hypoparathyroidism also, the patient will be having hyperparathyroidism on the patient will be having hyperphosphatemia only, not hypo. In hypoparathyroidism, the PTH level is decreased. The decline in PTH level will promote the increase in phosphorus level. Please be very clear. In case of tumor lysis syndrome, also hyperphosphatemia is seen. Along with hyperphosphatemia, what are all the conditions you can see in tumor lysis syndrome? Hyperphosphatemia, hyperkalemia, and what are all the conditions you can see? Why not C? See, children, in hypoparathyroidism, the PTH level, the parathyroid hormone is going to reduce. This in turn going to cause reduced renal phosphate excretion. Okay, if PTH is going to cause, this is going to cause reduced renal phosphate excretion. Yes, right. Be very clear in this. Whenever the patient is having any form of renal failure or hypoparathyroidism because of the PTH interaction, the patient will be going for hyperphosphatemia, not hypo. Now answer me again. Tumor lysis syndrome is again an important point. Along with hyperphosphatemia, hyperkalemia, what are all the other things you can see? Hyperuricemia and hypocalcemia. These are all the things you can see in case of your tumor lysis syndrome. Again, you have to remember. These all three conditions will cause hyperphosphatemia, whereas malnutrition, starvation, chronic alcoholism, refeeding syndrome, these all causes hypophosphatemia. This is very, very important, right? Let's go to the next question. Yes, now answer me. A client is at the risk of development of a potassium level of 5.5 milliequivalent liter. Which client is at the risk of development of a potassium level of 5.5? Here they are asking which client in the given case scenario, which are the patient are at higher risk of going to hyperkalemia? Now give me the answer. The normal potassium is 3.5 to 5, right? The patient is on hyperkalemia. Now tell me, what is the answer? Very good, very good. I think there is no explanation needed for this particular question. The client who has sustained traumatic brain injury, any form of cellular destruction, what it will do? This cellular destruction, burns, sepsis, okay, burns, sepsis, chemotherapy, these all going to cause what? The potassium shift outside the cell. Because of the cellular damage, the potassium inside the cell is going to come outside the cell. This is going to cause hyperkalemia. So any form of cellular destruction, which is maybe a traumatic burns or any form of injury and sepsis and chemotherapy, they are going to cause what? Cellular destruction will cause hyperkalemia. Remember that. On the other hand, what about colitis? A colitis kind will have decrease in potassium, hypokalemia, because of excessive GI loss of potassium, right? And what about this Cushing syndrome? In Cushing syndrome, the patient will be having hyperaldosteronism. What is the action of aldosterone? Aldosterone, which is going to act in your ENAC. That is your epithelial sodium channel. This is going to cause sodium and water reabsorption. Whereas potassium and hydrogen excretion, right? So obviously, because in Cushing syndrome, the hyperaldosteronism you can see, which is going to cause increased amount of potassium excretion, which is going to cause what? Hypokalemia. The client who overuses laxative, what is going to happen? Potassium overusage of laxatives will lead to hypokalemia only, not hyperkalemia. Very good, very good, very good, very good, Neha. Very good, Sugant. Very good, Sanjeet. Very good, very good, very good. The client who has overusing of laxatives will also having potassium loss only. So next question. The nurse reviews the blood gas results of a client with atelectasis. Remember, the nurse analyzes the result and determines that the client is experiencing respiratory acidosis. Which result validate the nurse finding? Respiratory acidosis. Respiratory acidosis, as I said you, when pH and PCO2 are going in same direction, it is metabolic problem. When it is going in reverse direction, it is a respiratory problem, right? So obviously the pH of this value, acidosis, so pH is going to be reduced. So obviously it is going to be reverse direction if it is PCO2. So PCO2 has to increase. So what is the correct answer? A is the correct answer. No more confusion. pH is reducing. PaCO2 is increasing. Here, normal limits. Here, alkalosis. The patient is going for alkalosis. So these are all the wrong answer. Your A is the correct answer, right? Excuse me. Next. Silver sulfadiazine is prescribed for the client with burns injury. Which laboratory finding requires follow-up by the nurse? Now tell me which of the laboratory finding which needs a follow-up by the nurse? Yes. Very good, very good. Appreciating students. Sanjeet, Tanu, Ankur, Sugant, Suman, Thunderbolt, Neha, Sunidhi, Preeta. Very good. Yes. Now tell me, what is the correct answer? A patient is going silver sulfadiazine, which is the most common drug which is used in case of burns injury management. So now tell me, what is the answer? Yes. White blood cell count of 3000 mm³ is the correct answer. Why? If you talk about glucose, it is within normal limits, and the platelet is also within normal limits. The magnesium level is also in the normal limits. The normal magnesium is 1.5 to 2.5. So it is also in the normal limits. What is the platelet normal level? That is 1,50,000 to your 4 lakhs. Right? 1,50,000 to your 4 lakhs. Your glucose level, that is 70 to 110 gram per DL. So that is also normal. But your white blood cell count, your normal white blood cell count is 4,000 to 11,000. So this is again what is causing, this is reduced. So this is reduced means the patient is going for leukopenia. Remember one thing about your silver sulfadiazine. Silver sulfadiazine is an important antimicrobial drug which is used, or the most common drug which is used in burns injury, right? This is going to cause discoloration on the skin, and this drug is very good for your Pseudomonas. This drug is very good for your Pseudomonas and gram-negative bacteria. Pseudomonas and gram-negative bacteria. What are the other components you know? Now tell me, what are all the other components you know under your burns management? First is your silver sulfur diazine. Next, we have silver nitrate. Silver nitrate we have. Okay, silver nitrate is going to cause blackish discoloration. Important update. Another important medication you have, that is your mefenide acetate. This mefenide acetate will penetrate into the wound and act as an antimicrobial component. It will penetrate the wound. So that's why it is very painful. This mefenide acetate is very painful because it penetrates inside the wound. And this particular drug can cause metabolic acidosis. Okay, this particular drug can cause metabolic acidosis. So this is very, very important point to note in NORCET-centric point. And another drug we have, that is your cerium nitrate. Okay, another drug we have, that is your cerium nitrate. And cerium nitrate is considered to be the best agent when comparing to all others. Coming back to the question, the white blood cell count is very much reduced, which is indicating the patient is going for leukopenia. And if the patient is going for leukopenia, he is at the higher risk of going for immunocompromisation and infection. Right? So that's why this is the correct answer. So next question. A nurse is monitoring a client for the signs and symptoms related to the superior vena cava syndrome. Which early sign of this oncology condition? Which is an early sign of this oncological condition? Yes. Use of bed cradle. Very good. These are all important nursing interventions. Now tell me, dear children, a nurse is monitoring the client for the signs and symptoms of superior vena cava syndrome. What is the early sign of this oncology emergency? Superior vena cava syndrome, which means that is the obstruction. That is the obstruction of your superior vena cava, as we all know. When there is an obstruction in the superior vena cava, what it is going to happen? There will be impaired. Very good. Periorbital edema is the correct answer. Please give a big round of applause to all the students. Sugandh, Suman, Thunderbolt, Neha, Bantishpa, Ankur. Very good, very good. See, periorbital edema is the primary thing. Arm edema is a late sign. Okay, late sign. Cyanosis is a late sign. Again, this mental status changes will also be the late sign. So this what happened? Impair venous drainage. Impair venous drainage from the upper extremity. Okay, upper extremity, head and neck. So primarily, because of the proximity of your superior vena cava and venous drainage, primary sign you will be saying early you can see the periorbital edema. This is a very, very repeated question as well. So it is very, very important to note. So what about cyanosis? Cyanosis and all, it is a late sign. Okay. Later it can happen. Even arm edema can also happen. That is also a late sign, right? So next question. The nurse manager is teaching the nursing staff about the signs and symptoms related to hypercalcemia. In a client with metastatic prostate cancer, what is the late sign of this oncological emergency? Now tell me, what is the late sign? Earlier question, we were discussing about the early sign. Now we're going to tell me what is the late sign. Now tell me tell me what is the normal calcium level. The normal calcium level is 8.6 to 10.2. Right, 10.2 milligram per DL. Right, normal calcium. Constipation. See, when comparing to pedal edema also, periorbital edema is the primary change here, Suganti. Right. First is periorbital edema because of the so much proximity. When comparing to your orbital and facial structures, Your extremities are down. First is periorbital edema, that is the first sign. Then only the patient will be going for peripheral edemas, right? That you have to remember. Right? Yes. Now tell me, what is the correct answer? Very good. What is the late sign you can see? Hypercalcemia, what is the late sign? Early sign and late sign. Now tell me, what is the late sign? What is the answer? Yes, yes, yes. Late sign, what is the answer? Early sign, what is the answer? Always remember, when the patient is going for hypercalcemia, the early signs or GI symptoms. The early signs or GI symptoms. Don't confuse your early symptoms with your late symptoms. Early symptoms, when they're going to ask you differentiate about early and late, then you should be very clear which is early and which is late. Right. So early GI symptoms is going to be what? That is your constipation. Yes, answer me in the chat box. Constipation, nausea, polyuria. Okay, polyuria and weakness and fatigue. Weakness and fatigue. Right. Now tell me, what are all the late signs? So obviously constipation, many people have answered that is not a correct answer. Right. In late signs only, the patient will be exhibiting neurological symptoms. Neurological symptoms such as your coma, okay, coma, confusions, and the most important thing you have to remember is ECG changes. ECG changes. Just now we have studied about the ECG changes of hypercalcemia. Now immediately list down what are all the ECG changes. Yes, very good. Please give a big round of applause to the people who have answered D as the correct answer. That because D is the correct answer. That is your Ankur, Neha, Sanjita. No, D is the correct answer. Please be very clear. Electrographical ECG changes is very important, dear children. We don't have any form of neurological symptoms. That is also extreme. Late sign means it is not will be having a simple headache. It is going to have a severe form of coma, confusion, lethargy, renal failure. Also, the patient can go in case of late. What are all the ECG findings? What are all the ECG findings? Short ST segment. Just now we have seen short ST segment. Yes, please answer in the chat box. Wide T wave. Short ST segment, wide T wave. And possible arrhythmias, and I said the patient even can go for heart block. The patient can even go for heart block, right? So ECG changes is the late sign, whereas your constipation is the early sign, right? Able to differentiate about hypercalcemia, right? Yes, very good, very good, very good. Thunderbolt, Sanjita, very good. So now going to the next question. A client with metastatic breast cancer is receiving tamoxifen. The nurse specifically monitors which laboratory value while the client is taking this medication. The client is taking tamoxifen. What is the important nursing monitoring of laboratory finding for this particular patient? Yes. Come on, answer in the chat box. Yes, I'm waiting for your answers. People are very fast. Very good, very good, very good. So this is a very common drug and you people are very clear in that. Like calcium level, you have to definitely monitor because tamoxifen is a selective estrogen, SERM drug. It is a selective estrogen. Yes, tell me, estrogen receptor modulator. It is both having agonist and antagonist effect on estrogen, right? So the client is specifically having bone metastasis, right? The client is specifically having a bone metastasis. Like they can go from metastatic breast cancer, they can go for bone metastasis. This can flare. This tamoxifen can flare bone metastasis. This is going to have an impending effect on calcium. Now tell me, either calcium is going to increase or decrease. Yes, calcium is going to increase or decrease. That is again another important point you have to tell me. Bone metastasis, the patient will go for bone metastasis once the patient is a metastatic breast cancer who is taking tamoxifen. There is chances it can flare a bone metastasis. Then what is calcium level you will be monitoring? What you will be seeing, either hyperkalemia you will see or hypokalemia you will see. Obviously, you will be seeing hyperkalemia, not hypokalemia, because of the bone metastasis. Glucose level, potassium level, prothrombin time, we will not be seeing. Right. Not hyper. Neha, very good. It is not hypo, it is hypercalcemia, dear children. Remember it. Next. A client is brought to the emergency department in an unresponsive state, undiagnosed of hyperosmolar hyperglycemic syndrome. The nurse would immediately prepare to initiate which anticipatory primary healthcare provider's prescription. See the question clearly. The nurse immediately prepares to initiate which anticipated primary healthcare provider's prescription. She has a list of prescriptions which she will perform immediately. Very good. So clear in some concepts. I'm really proud of you, children. Very good, very good, very good, everyone. So listen, a patient with hyperosmolar hyperglycemic syndrome will be having a severe form of dehydration. Severe form of dehydration. The water loss will be greater than 9 liters. So the primary responsibility of a healthcare provider or a nursing person is to stabilize the patient with intravenous infusion of normal saline. Okay. When comparing to other interventions, this is going to be the primary intervention. When we talk about endotracheal intubation, if the patient is not stable, he's hemodynamically unstable, at that time we are going for this. What about 100 units of NPH? These hyperglycemic, these are life-threatening conditions which is going to cause hyperglycemia. NPH can be administered in subcutaneous only. Always remember, regular insulin. Insulin can be only administered through IV. That is only preferred, not NPH. Intravenous infusion of normal saline will be the most important management which we have to do for the patient, right? In order to restore the fluid balance, right? What about intravenous infusion of soda bicarb? When you will give soda bicarb to the patient? Whenever the patient is going for metabolic acidosis. Metabolic acidosis. When the patient will go for metabolic acidosis. If the patient is a case of DKA, he will be going for metabolic acidosis. But in your HSS, you will not having any acidotic event. So the primary intervention is to administer the intravenous infusion of your normal saline and restore the dehydration of the patient. Right? Yes, very good. Regular insulin only will be administered in IV. Don't, like whenever you think about HHS and all, you will be thinking that we will go for insulin only, but you should not think like that, right? Yes. A client has just been admitted to nursing unit following thyroidectomy. Which assessment is the priority for this client? Now tell me, a classical clinical question. Now you have to tell me what is the assessment, which assessment is priority for the client? Which is the priority assessment, a priority based question? Yes, answer me. Hoarseness. What is done with when the patient is a case of thyroidectomy, which means the thyroid organ is removed, right? Audible stridor. Again, clinical kids have answered it so fantastically. Suman, Joy, very good. Audible stridor. Why audible stridor? Hoarseness is indicating what? Laryngeal nerve damage. Laryngeal nerve damage. Hypocalcemia. Whenever you have an accidental removal, like The adjacent organ is a parathyroid gland. The adjacent hormone is a parathyroid gland, right? So when there is a damage, this may lead to hypocalcemia. But audible stridor is indicating the narrowing of the airway. Whenever you try to push a air into a narrow space, there will be more sound. That is the audible stridor. Audible stridor is indicating the airway compromise, the narrowing of the airway. So that will be the primary responsibility. Airway is the primary responsibility here when comparing to. Hoarseness of voice is simply because of laryngeal nerve damage here. When comparing to the laryngeal nerve damage and its management, audible stridor, which is indicating the patient is struggling for breathing. There is a swelling, there is an edema, there is an hematoma, which is compressing the airway, and that is producing the audible stridor, right? So this is very, very, very important primary action. Edema at the surgical site. Again, when comparing to edema and a breath problem and a respiratory problem, audible stridor is going to play an important role, right? Let's go to the why not D? See, children, your airway clearance, Neha, airway clearance is very important when comparing to the edema. Edema management is very important when comparing to the audible stridor. You have done the assessment and you have found there is a narrowing of the airway. So that will be the priority assessment which you have to do. Right? Next. The nurse is assessing a client of 24 hours after cholecystectomy. The nurse notes that the T-tube has drained 750 ml of green-brown drainage since surgery. Which nursing intervention is most appropriate? Now answer me. A, B, C. Very good, very good. Again, the next question. Answer me. Airway first. Very good, Thunder. Yes, now tell me the answer for the next question. Notify the surgeon. Document the findings. Yes. Please give a big round of applause to Pavan. Very good, Pavan. Please give a big round of applause to Gayatri. Again, Pavan. Pavan has completely reinforcing his answers. Very good, Pavan. Like your Entu. Gayatri. Again, Pavan and Gayatri on the both the hands, they are telling it is D, it is D, it is D. See, remember, children, a patient post cholecystectomy, the drain fluid of the expected drain fluid, okay, for the first 24 hours is around 500 to 1000 ml. That too, the quantity of the quantity, and you have to remember the quantity is 500 to 1000 ml per day. And what is the observance you have to do? Initially, there will be reddish, brown, and reddish, like it will be an active bleeding kind of drainage. Later, it will become greenish brown because of the bile, right? So this greenish brown drainage is there, which means it is normal. And again, when we talk about the quantity, it is going to be 500 to 100,000 ml, which is again a normal thing. So everything is normal. You are not supposed to clamp the T-tube. It is not at all advised. Nursing intervention to clamp the T-tube is not at all advised. Yes, according to time, it is normal. Very good. Very good, Suman. Irrigating the T-tube is not at all advised. Notify the surgeon. Why we have to notify? No, because it is a normal finding. You have to just simply have to document the finding. Unless until you see active bleeding, which is very, very reddish, then you have to definitely notify to the surgeon. But here, document the findings is the correct answer. Right? Very good. So the nurse is monitoring a client with a diagnosis of peptic ulcer. Which assessment finding would most likely indicate perforation of the ulcer? Yes. See the abdominal drain, the nurse notes the T-tube has drained. Right, you have the word clearly that the T-tube is draining. So it is completely talking about the normal T-tube drain, right? Yes, a rigid, broad like abdomen. Again, a patient is a case of peptic ulcer and indicating perforation of the ulcer. Once there is a perforation of the ulcer, what is happening? The peptic ulcer, when it is perforated, what is happening? There is a ulcer erodes the stomach or the duodenum and allowing the gastric secretions on the duodenal content into the peritoneal space or the peritoneal cavity. This is going to cause peritonitis. This is going to cause peritonitis. The ultimate classical feature of peritonitis is your rigid, broad like abdomen with tenderness. With tenderness. What about bradycardia? The patient will be having tachycardia, not brady, in case of this kind of peritonitis and perforation. Okay, halitosis, that is not completely related. Nausea and vomiting, no. The primary finding which you can see is peritonitis findings. That is a rigid road-like abdomen. The next question. The emergency department nurse is assessing a client who has sustained blunt injury. Whenever you see a word blunt injury, remember it is a closed. It is a closed injury of the chest wall, which finding indicates the presence of pneumothorax. Yes, very good, Tanda. Along with that, the patient will be having hypotension and tachycardia in peritonitis. This is also a very, very important finding you have to remember. Now tell me, in emergency department, the nurse is assessing a client who has sustained a blunt injury in the chest. What finding will be present if the patient is a case of pneumothorax? Obviously, it is a very, very easy question. What is meant by pneumothorax? Pneumothorax is the collection of air. Collection of air in the pleural space, right? It's a collection of air in pleural space, right? So the patient will be having diminished breath sound. That will be the correct answer. Why? Because it is a closed and blunt injury. Either the patient will be having diminished breath sound or absent breath sound. Absent breath sound. Along with that, what are all the expected findings the patient might have? Now tell me in the comment box. Yes, very good. Please give a big round of applause. Sugant is following like what I have said in the initial class, not only telling what is the correct answer, but you also have to list what are all the important points you have to remember while studying about this particular condition. Along with this pneumothorax, what are all the findings? Along with diminished breath sound, absent breath sound, the patient will be having dyspnea, chest pain, like very good. Hyper resonance can be heard on percussion. Okay, on percussion, hyper resonance. Sometimes when the condition is proceeding, the patient will also go for subcutaneous emphysema. Okay, subcutaneous emphysema. What about your heart rate? The patient will be going for tachycardia. Okay, the patient will be going for tachycardia and cyanosis in case of severe condition. Barrel chest is seen in case of COPD and emphysema, specifically in emphysema. And low respiratory rate, no. Suckling sounds at the site of injury. Now tell me, suckling sounds at the site of injury will be heard in which cases? Suckling sound at the site of injury will be heard in which cases? This will be heard in case of your open injury. Yes. Suckling sound. Okay, you can see a suckling sound at the site of injury in case of your open injury, which is leading to pneumothorax. You can hear this suckling sound. Right? Yes. Open pneumothorax. Yes. So next, a nurse is assessing the respiratory status of a client who has suffered a fractured rib. The nurse would expect to note which findings? Fractured rib. Suddenly your thinking will be going in a different perspective. Let me test you, like, what is the correct answer? A fractured rib. What is the correct answer? Yes, very good, Gayatri. Yes, the expected mistake everyone is doing. Very good. Very good, my dear children. The expected mistake. See, children, paradoxical respiration will be seen in case of your failed chest. Okay, it's seen in case of a flail chest. Flail chest is caused by what? Multiple rib fractures. Multiple rib fracture. Which means, what is the exact definition? Greater than or equal to 2 rib fracture or in 2 different places. In 2 different places. Which is going to cause this paradoxical respiration. What does it mean by paradoxical respiration? On inspiration, normally, when you inspire, the chest will move outward, but here it will move inward. On expiration, it will move opposite. When you expire, the chest will move inward. Here it will move outward. That is the thing. Right? Yes. Now tell me what is the correct answer. Now also many students, yes, some people have came with the correct answer. Very good. That is, give a big round of applause to Mangalya, Neha, Shwarnali, Suman, Neha, Tanu, Gayatri, Sanjita. Yes. Pain, especially with inspiration. These patients, what they will do, a single rib is fractured, suffering from a fractured rib. It is very singular. It is not indicating any form of, he is not telling any status like it is a multiple rib fracture. Here they are simply telling it is a rib fracture. They are not telling it is multiple. Okay. Fractured rib. It is very, very clear. It is a singular. Right. So the nurse would expect the findings like pain, especially with inspiration. The patient will be having a localized pain and tenderness during inspiring, because when there is an inspiration, this is going to cause an abnormal pain. Right. Slow or deep respiration. The patient may go for slow. No. The patient will go for deep respiration. No. Deep respiration is going to cause severe pain. So the patient will not go for deep respiration. Rapid respiration the patient will be doing, because when we go for deep inspiration only, the patient will be having pain. So he will do a rapid shallow respiration, but a deep respiration he will never do. So the correct answer will be your pain, especially with inspiration. Okay, pain, especially with inspiration. Always remember, flail chest is happening with multiple rib fractures, not for single rib fractures. The multiple rib fracture definition also, it should be very clear. It should be greater than or equal to 2 rib fracture in 2 different places. Okay, which is going to cause you, very good, which is going to cause you flail chest. Next, we'll go to the next clinical question. A nurse is evaluating a client's response to cardioversion. Which assessment would be the priority? See, when we think about very much advanced questions and all, don't think so advanced and all. Because first and foremost, the NORCET examiners want to analyze either you are a safe nurse or not. When you put in a very critical situation, either you can able to tackle or not, whether you are going to be a good nurse who is going to tackle that particular situation so effectively with a clinical knowledge, not only theoretical. So clinical questions are mostly asked in your examination, right? So be very clear on this. Now tell me answer for this question. The nurse is evaluating a client's response to cardioversion. What assessment would be the priority? You know, cardioversion will be always done with, cardioversion will be always done with sedation. Cardioversion will be always done with sedation or anesthesia, and it is always an elective procedure, right? It is always an elective procedure. It is not an emergency procedure. It is an elective procedure. Yes. See, for those who are answering D, Already the patient is going for sedation. So loss of consciousness will be, the patient will be already in loss of consciousness because the patient is on sedation. Post recovery, you will be analyzing whether the patient is reverting or not. You will be assessing the consciousness. What is the priority assessment? No blood pressure is not. The airway pattern, see, since I'm administering the sedation, there will be a lot of effect that it may reduce the airway reflexes. So my primary responsibility is to assess the respiratory status of the patient rather than everything. Oxygen flow rate. Once the patient is unstable, we are going for it. Right. Airway patency has to be evaluated. This can even suggest the patient will go for any form of respiratory obstruction. So that has to be prevented. In ABC protocol, your blood pressure will definitely not come. What about oxygen flow rate? Oxygen administration is important, but it is a secondary, not a primary. It is a secondary action. It is not a primary. Be very clear. It is a secondary, not a primary. What about level of consciousness? No, once the patient is reverted, you're going to check about it, right? Yes. The next question. A client is being treated with prosinamide. Prosinamide is your class 1A drug. That is your sodium channel blocker. Prosinamide, your disopramide, your quinidine, everything are coming under your class 1A drugs. For cardiac dysrhythmias, following intravenous administration of the medication, the client complains dizziness. The client is complaining dizziness. Which intervention would the nurse implement first? Which intervention? Please be very clear. Which intervention would the nurse implement first? Yes. Airway should be always given priority. Now tell me which intervention should be given first. Would you implement first for a patient on prosinamide therapy? After the medication, the client is feeling dizziness. So what is the primary intervention? Many people are answering A. I'm waiting for the correct answer. Yes, please give a big round of applause to this warrior. Neha, Suman, Diksha, Sharma. Very good. Again, some people, one person name is written in Arabics, which I cannot read. Sorry, dear. Okay. So Neha, very good. See, auscultating the client for apical pulse and blood pressure. See, the patient prosinamide has various side effects. It causes hypotension. It causes hypotension, dizziness. In severe cases, it causes loss of consciousness, QT prolongation, everything. You all know class 1A and class 3A drugs causes, class 1A and class 1C drug causes QT prolongation, as you all know. So prosinamide, quinidine also causes QT prolongation. So what you people will think, like you have to measure the QRS interval duration. But before taking an ECG and monitoring the electrographical findings, the primary assessment implementation, primarily which is accessible, first you can assess the apical pulse and blood pressure of the patient when comparing to monitoring or evaluating. Detecting QRS and tachyarrhythmias, first you have to assess the patient, then the monitor, then the ECG strip. So patient is first priority, then the monitor. This is how you have to think. It is a second priority, right? So ausculting the client's apical pulse and blood pressure, that will be the primary important finding you have to do, so that the patient, you will be assessing whether the patient is hemodynamically stable or not. Hemodynamically stable or not, right? Next, go to the next question. A client with chronic kidney disease returns to nursing unit following a hemodialysis treatment. On assessment, the nurse notes the client temperature is 101 degree, 101.2 degree Fahrenheit. Which nursing action is most appropriate? Now tell me. We have answered various clinical questions, which is testing this kind of skill. Now you have to tell me the answer for this. Yes, Preeta, very good. Deepali, very good. The next question. Answer for the next question. You have started answering for the next question? Yes. See, the patient is on chronic kidney disease and returns to nursing unit after a hemodialysis treatment. On assessment, the nurse notes the client's temperature is 101 degree post-dialysis, which is indicating the patient is having systemic infection. Systemic infection. Encourage fluid intake, no. Fluid restriction the patient will be having. Continue monitor vital signs. No, this is not going to have any effect because the temperature is rising. That is also post-dialysis. So this is very, very important highlighting point you have to remember. Notify the primary healthcare provider and monitor the site for the shunt for infection. You have observed the patient is on hyperthermia, like the patient is on hyperthermia, and this is indicating the patient is going for systemic infection. So primarily, you have to immediately notify the primary healthcare provider. Then only you have to monitor the site for any infection or not. Primarily, with the help of the temperature, you have came to the conclusion the patient is having infection. Later, after informing to the physician immediately, okay, then you have to go for the monitoring the site and infection. This will be the first priority, and this is the second. That is how you have to classically differentiate, right? C will be the correct answer, not D. You know the patient is having systemic infection. Already you have found out. First, informing the physician regarding this, and the temperature is quite high. Post-dialysis patient, hemodialysis patient. So it should be very clear in these things. Yes, the next question. The nurse is instructing a client with diabetes mellitus about peritoneal dialysis. The nurse tells the client that it is important to maintain the prescribed dwell time for the dialysis because the risk of which complication? The prescribed dwell time has to be maintained in case of peritoneal dialysis. Why? Which complication can arise when there is a prolongation of the dwell time? Prescribed dwell time. What is the problem here? Again, you can take the keyword from the questions also sometime. Patient is a case of diabetes mellitus. And you know, in peritoneal dialysis, we also have an glucose as an important dialysate. Right? Prolonged exposure, prolonged dwell time to the glucose can cause hyperglycemia. Right? The primary complication is hyperglycemia when comparing to others. Right? Glucose containing dialysis, when the dwell time is increasing, this is going to cause hyperglycemia. What about peritonitis? Peritonitis happens when you break the aseptic precaution. There is no word which is telling that you have break the aseptic precaution or something which is related to infection. What about hyperphosphatemia? See, in renal dysfunction, when the patient is having renal dysfunction only, he is going for peritoneal dialysis. So obviously, I have instructed you that if the patient is going for renal dysfunction, the patient will go for peritoneal dialysis. Renal destruction, there will be poor excretion of phosphate. So the patient will be going for occurs in renal dysfunction, but it is not primarily related to your dwell time. Disequilibrium syndrome happens with hemodialysis. Hemodialysis, not peritoneal dialysis. Right? Yes. The next question. A client newly diagnosed with chronic kidney disease recently has begun hemodialysis. Knowing the client is at the risk of disequilibrium syndrome, the nurse would assess the client during dialysis for which associated manifestations. Like you know that the client is at the risk of disequilibrium syndrome. Like what the nurse would assess for the client during the dialysis for which is associated manifestation. Along with that, focus on disequilibrium syndrome. What are all the findings you see in disequilibrium syndrome? When the client is new for hemodialysis, the patient will go for disequilibrium syndrome. Yes. headache, deterioration in the level of consciousness, twitching, which is happening because of what? Which is happening because of your osmotic gradient shift. Okay, this is happening because of your osmotic gradient shift, and which is causing cerebral edema, which is causing cerebral edema and increase in ICP, which is provoking the patient to go for this headache, deteriorated level of consciousness and twitching, right? So D is the correct answer. Don't confuse yourself. Dialysis disequilibrium syndrome, the primary thing is neurological symptoms you will be seeing in the patients because of cerebral edema and increased ICP. Search the findings which is showing this neurological symptoms. Along with that, you can also see headache, nausea and vomiting, confusion, seizures, everything you have to remember, right? Yes, D is the correct answer. Next question. A nurse is caring for the client following craniotomy for removal of an acoustic neuroma. So assessment of the cranial nerve would identify a complication specifically associated with the surgery. Acoustic neuroma is talking about which cranial nerve? Now answer me. Acoustic neuroma is talking about which cranial nerve? It is talking about your 8th cranial nerve, that is your vestibulocochlear. Your vestibulocochlear is located in your internal auditory canal. It is located in your internal auditory canal. It is located in your internal auditory canal. What is the adjacent structures which can be possibly damaged because of the surgery of acoustic neuroma resection? Yes, Joy, Priyanka. I want the answers. See, whenever you see a case of acoustic neuroma where the vestibulocochlear nerve tumor you're seeing, the first primary affected thing is your facial nerve, right? Facial nerve is mostly affected. Very good, Sanjita. Why? See, they have a very close anatomical relationship. They have a very close anatomical relation. What this anatomical relation is going to do, this is the surgical removal can compress or injure your 7th cranial nerve. So what are the signs and symptoms you can see? The patient may project decline in corneal reflexes, okay? Impaired blinking, decline in corneal reflex. Sometimes the patient will be having drooping of eyelids. Okay, there is no proper facial movements. So these are all the findings which you can see for a patient with a cranial nerve 7 damage. Whatever findings you see in cranial nerve 7 damage, all the findings you can see when the patient is a case of acoustic neuroma surgery patient. Post-operatively, we are expecting, okay, this complication can specifically associated with this. Remember, 8th cranial nerve, vestibulocochlear surgery, vestibulocochlear cranial nerve surgery or neuroma can directly affect your facial nerve. Then what is the secondary nerve which can also be affected is when first is your facial and next is your 5th cranial nerve, that is your trigeminal. That is your trigeminal. That also you have to remember. Right. Very good, Manvi. So next we will go to the next question. A client recovers from a head injury, is participating in a care. The nurse determines that the client understands measures to prevent prevents elevation in the intracranial pressure. If the nurse observes a client doing which activity? See the structure of the question, like it is quite confusing. It will take time for, it will take some time for understanding these questions. The client recovering from a head injury is participating in care. The nurse determines that the client understands measures to prevent elevated intracranial pressure. What you're trying to tell is that the client is understanding that if I'm not doing these particular things, my intracranial pressure is not going to increase. Like, so if the nurse observes the client doing which activity, like if I'm doing this activity, my intracranial pressure will be reduced. Exhaling during reposition is very good. This exhalation during reposition is going to cause and reduce intrathoracic and intra-abdominal pressure, which is going to further reduce your ICD, right? ICP. So obviously, this is the level of understanding that the patient is feeling that whenever you're repositioning the patient is feeling that I have to exhale so that I can reduce the intrathoracic and intra-abdominal pressure. Blowing the nose is going to cause increase in ICP. Isometric exercises also increase in ICP. Coughing rigorously causes increase in ICP, right? So next question. A nurse is caring for a client being treated for fat embolism. After multiple fracture, so which data would the nurse evaluate as the most favorable indication of resolution of the fat embolism? The nurse is telling a patient is a case of fat embolism after multiple fractures, and I'm evaluating. And what is the most favorable indication that I'm telling that the patient is completely resolved from fat embolization? Yes, I want the answers. Oxygen saturation C. Sanjita, is oxygen saturation C is the correct answer? The normal oxygen saturation is 95 to 100%. Here also you have placed that respiratory parameter is very important. Obviously, respiratory parameter is very important, but the normal level is this. Minimal dyspnea. No, the patient should not have any dyspnea. The oxygen level and breathing pattern should be normal for this patient. Any correct answers? See, fat embolism is commonly occurred when there is a long bone injection, long bone fracture, right? So here, early manifestation. What is the early manifestation of fat embolization? Early manifestation. Early manifestation is neurological symptoms. Neurological symptoms. What are all the neurological symptoms you can see in these patients? That is your altered mentation because of cerebral hypoperfusion. Altered mentation because of cerebral hypoperfusion. Right. So the correct answer is A. Now give a big round of applause to Gayatri, Deepali, Neha, Swarnali, Preeta, Anjana, Joy. If the patient is having a clear mentation, where he is not having any form of altered neurological symptoms, the most favorable indicator for resolution is normal cerebral perfusion and oxygenation. So cerebral mentation is indicating normal cerebral perfusion and oxygenation. Right? So atrial oxygen level. What about this extraatrial oxygen level? Atrial oxygen level normal is 80 to 100. So it is also wrong. This is also wrong. Right? So next question. Next, we have another important 10 to 15 important surgery related MCQs. So be with me in the class. Don't leave the class. We have very, very important discussion after these MCQs, right? A client with acquired immunodeficiency syndrome is diagnosed with cutaneous Kaposis sarcoma. Based on the diagnosis, the nurse understands that it is confirmed by which? Cutaneous Kaposis sarcoma, how you are doing the diagnosis. If you are answering it correctly, I will move to the next question. Yes, Kaposis sarcoma is always associated with your herpes virus, right? Kaposis sarcoma is associated with your herpes virus and your HIV AIDS virus, right? That too, herpes virus 8 specifically. If there is a question, you can answer. Right, now tell me what is the correct answer? Yes, C is the correct answer. See, C is the correct answer. Very good. Positive punch biopsy of cutaneous lesion. Immunodeficiency patient, cutaneous Kaposi sarcoma. It is a what? An immunocompromised patient, you can see this, right? So the histopathological confirmation is very important. Histopathological confirmation is very important in the diagnosis. So histopathological confirmation will be done by your positive punch biopsy of your cutaneous lesion, right? Yes. How should the nurse monitor for the complication of subcutaneous emphysema? Clearly answer, this is assessment-based MCQ. Now tell me, subcutaneous emphysema. Very good, Gayatri. Very good, Suman. Very good, Nagaraj. Very good, Suganti. Very good, Neha. Now tell me, how should the nurse monitor for the complication of subcutaneous emphysema after the insertion of the chest tube? Either I have to do auscultation, I have to do palpation, or I have to observe the patient. Subcutaneous emphysema. Yes. Answer me. Many students are answering A. That is absolutely the correct answer. Right. A is the correct answer. See, first and foremost, subcutaneous emphysema, that is the accumulation of air in the subcutaneous region because of your preceding condition. So here, rather than auscultation, the primary confirmatory, okay, at the site after the insertion of the chest tube, the complication of the subcutaneous emphysema can be monitored only by palpating the tube site for the crepitus, which is identifying that there is some subcutaneous emphysema accumulation. Auscultation of the breath sound is not going to tell you about anything. Crackles and bronchi, they are different. Observe the client for presence of barrel-shaped chest, which is seen in emphysema. Compare the length of inspiration with the length of expiration, which is not going to work. First is palpation, subcutaneous emphysema, that is in the subcutaneous region. So I have to palpate at the insertion site and you have to monitor the crepitus, right? Next question. Again, a long question, which are expectedly asked in your examination. Now, come on. A client started a 24 hours urine collection. Please observe my wordings. A client started a 24 hours urine collection test at 6 a.m. The unlicensed assistive professional, for example, a GDA Bhaiya, reports discarding a urine specimen of 250 ml at 10 a.m. She started at 6 a.m. But what happened? The Bhaiya, like the helper, has discarded the 250 ml of urine for the client under your 24 hours urine collection. Right? By mistake, but adding all the specimen to the collection container. Apart from the 250 ml, which was discarded at the 10 a.m. by mistake, rest of the urine from 6 a.m. morning to the next day 6 a.m. was collected. Only the 250 ml has been discarded. Right? So, what action should the nurse take? Classically, as a clinical person, you people have to answer me for this question. Many people are giving mixed answers. Right? What is the correct answer? Manvi, please give her a big round of applause. She is a pure clinical nurse. I'm telling it is a 24 hours urine collection. Okay. I'm going to assess the kidney function, the urea, the creat, the protein, the uric acid, everything for the 24 hours. If you are discarding the 250 ml, there can be a bias. There can be a misinterpretation. So I'm not supposed to do that. Adding 250 ml of the total output after the 24 hours. No, I want in that particular 24 hours, not after that. Discard the urine container and restart the 24 hours urine collection tomorrow morning. Yes, this will be the appropriate action you have to do. You have to completely discard whatever you have done the collection. And what you have to do, you have to ask the patient to again collect the urine for the next 24 hours without any error. Discard the urine and container, have the client void, add urine to the new container and then restart the test. Discard the urine and container, have client void, add urine to new container and then restart test. No. Again, you should not do. that has to be completely discarded. You are not going to add the urine to any form of new container. You're going to completely discard the container and the urine, and you're going to start a new form of sample collection. Relabel the same sample containing 6 a.m. to 10 a.m. No. 24 hours urine collection starts from 6 a.m. to 6 a.m. Right? Yes, the correct answer is B, not C. The correct answer is B, not C. What I have to do, even though you are discarding 100 ml or 50 ml from my 24 hours old sample, I'm going to discard the whole sample and I'm going to collect the new sample. I'm going to discard both the container, both the urine, and I'm going to start the new 24 hours urine collection. Right? Be very clear in that. You're not going to compromise anything because you're sensibly collecting the data. You're sensibly analyzing the 24 hours urine sample. There can be possible misinterpretations when you're discarding few amount of sample or you're adding few amount of sample from the next day, right? You should be very clear in that. Now, we are going to come and deal with some advanced questions now. Now tell me, when is your Oshner-Sharon regimen, okay, aborted and emergency surgery is done in case of appendicular mass? Yes. When is your Oshner-Sharon regimen is aborted and emergency surgery is done in case of appendicular mass? What is meant by this Oshner-Sharon regimen? Now tell me that first. Many people are answering C. The patient will be having decline in the abdominal pain. Is the patient will be having decline in the abdominal pain? Be very clear, children. Please think about it. See, whenever the patient is coming in the case of appendicular mass, it is not an actual appendicitis, but it is an appendicular mass where the patient is having an enlarged appendicitis, which is not having any form of perforation or any form of infection. So, for interval appendectomy, for example, initially what we will do, we will assess the abdominal pain level, okay, tenderness, temperature, size of the lump, everything you will be monitoring. Then, if everything is fine, there is no abnormal finding, then you are going to administer analgesic, antibiotics, okay, analgesics, antibiotics, and IV fluids in the management. Then what happened? You will be stabilizing the patient, and you will be doing the appendectomy after 6 weeks. Okay, after 6 weeks, what we are doing? We are doing appendectomy. 6 weeks, we are doing appendectomy. Once the patient is becoming stable, like all the infection, perforation, everything is reduced, and the patient is becoming stable. Right. After 6 weeks, I'm going to do appendectomy. Right. Now, he is telling when it is aborted, which means when this will not be utilized. Yes, very good, Anjana, Vel Murugan, Manvi, Neha, very good. When there is a rise in pulse rate, when there is an increase in abdominal pain, an increase in size of the mass, which means, what it means, rise in pulse rate, tachycardia, which means it indicates systemic sepsis. It is indicating sepsis. Then what about increased abdominal pain? There is, from the enlargement, it is getting perforated. It is getting perforated and increased the size of the mass. It is becoming even more worst abscess. abscess with lot of infection. So obviously I have to abort it and I have to do emergency appendectomy. Right here, I am not going to follow this Oshner-Sharon model, and I'm going to post the surgery after 6 weeks after stabilizing everything. Right here, immediately the patient has to be done with the emergency appendectomy. Right. So A is the correct answer. Fall in pulse, no. Increased abdominal pain is correct, but no change in size of mass. No. Rise in pulse rate, it is correct. Decreased abdominal pain, no, it is wrong. Increased in size, this is also correct. So this 3-tier options, you have to check each and every option is correct or not. Fall in pulse is wrong. Decreased abdominal pain is wrong. No change. 3 of them are wrong. Right. So A is the correct answer. Right. Next, we will move to the next question. A 50 years old male with varicose vein in the lower limbs has developed a itching and ulceration around the ankle and calf region for few days. Which type of ulcer is likely to develop in long-standing chronic venous ulcer? Yes. Now answer me, what is the correct answer? Yes, many people are answering it as Marjolin's ulcer. Yes, it is a malignant transformation. It is a malignant transformation. A patient of post burns. Okay, post burns, varicose vein. So these patient, okay, they develop these ulceration. When this ulceration is not treated properly, it will go for malignant transformation, which is termed as your Marjolin's ulcer. Right? That is termed as your Marjolin's ulcer. This is varicose vein is your chronic venous hypotension, right? It is your chronic venous hypertension. Right. When it is untreated, it will go for this malignant transformation that is termed as your Marjolin's ulcer. Upper apostosis ulcer, I'll show the image of this. This is your aphthous ulcer. Right. This is your aphthous ulcer. Right. This ulcer is specifically happening in your oral cavity. Right. This is in your oral cavity, non-keratinized. These are termed as like it occurs in your oral cavity and it is a non-keratinized region, right? And this is your image of your pressure ulceration based upon the various stages and degrees. And this is again your necrotizing fasciitis. This is your necrotizing fasciitis. So what is this necrotizing fasciitis? Necrotizing fasciitis means a rapid or severely spreading infection. Okay, rapid or severely spreading tissue infection. That is your necrotizing fasciitis. So here you can see erythematous and gangrenous formation you can see, and you can also see blisters and bullae. These are the classical findings of your necrotizing fasciitis. Pus collection, swelling, and you can also see necrotic fascia and muscles also you can visibly see. So these are the classical findings of your necrotizing fasciitis, right? Yes. Next, we will go to the next question. A 45 years old male was rescued from a burning building and brought to an emergency ward with severe burns over entire body, including the entire circumference of the abdomen. Entire circumference of the abdomen, highlighting, please note it down. Despite initial resuscitation and fluid administration as per Parkland formula, and I hope all of you know the updated Parkland formula, that is your 2 ml into your total body surface area into your weight. Right? Don't confuse yourself. That is for your scald and flame burns. If it is a electrical burn, it is going to be again 4 ml. Right? 4 ml into your total body surface area. Right? Now tell me the answer. Despite initial resuscitation and fluid administration as per Parkland formula, the patient still had decreased urine output and hypotension. See, very, very important clinical point you have to remember. Entire circumference of the abdomen is burnt, and the patient is also exhibiting decline in urine output and your hypotension, decline in BP. What is the most appropriate treatment? What you will do? Yes. Yes. Now tell me, what is the differentiation? What is the answer? Extensive excarotomy. For circumferential burns of the abdominal, do we do excarotomy? Many people are answering C. See, the condition is C. The patient is going for circumferential abdominal burns. So you know a condition called abdominal compartment syndrome? Abdominal compartment syndrome. Now, abdominal compartment syndrome, as you all know, the important definition, please remove it. The intra-abdominal pressure, okay, the IAP, the intra-abdominal pressure, if it is greater than, okay, if it is greater than or equal to 12 mm of Hg, we are telling the patient is going for intra-abdominal hypertension. When we tell it is an intra-abdominal compartment syndrome, when the I'll expand and write, when the intra-abdominal pressure reaches greater than or equal to 20, excuse me, greater than or equal to 20 mm of Hg, then we are indicating it is the abdominal compartment syndrome. And the most important clinical classical feature of your abdominal compartment syndrome is decreased urine output, which you classically see here because of decline in the venous drainage. And also you can see decrease in cardiac output also, which is leading like hypotension also you can see. This urine output is indicating there is a poor renal perfusion, and decrease in your hypotension and decline in the cardiac output is declining. There is a cardiac compromise also. So the primary thing what you have to do is, okay, the primary thing what I have to do is emergency decompressive lap. I will talk about burns, don't worry. First, we will complete this question. We have to do emergency decompressive laparotomy only. Escharotomy is not going to work. I'll tell you where escharotomy is going to work. Here, the patient is going for decline in urine output, which means a poor renal perfusion. And the patient is going for hypotension, which is the patient is going for hemodynamic instability. Here, the primary responsibility of me is to reduce that particular pressure in the abdominal area. So what I have to do, I have to do an emergency decompressive laparotomy. That is preferred. Appropriate treatment they are asking. We are not going to perform it. Appropriate treatment is emergency decompressive laparotomy, not your escharotomy. I'll again tell you, if ICU admission and fluid resuscitation with colitis is going to start, again the patient condition is so much declining. If you do fluid resuscitation, it is going to further causes more edema because already the patient urine output is very less. Extensive escharotomy is not an option. That is for circumferential burns of your limbs, not for your abdomen. And administer intravenous vasopressors. That is going to further increase the complications. So if you see, the important finding which you have to remember is, for circumferential limb burns only, you are going to do escharotomy. Circumferential limb burns, not in case of your circumferential limb burns, not in case of your what? Abdominal compartment syndrome. Again, when talking about burns, see children, burns, the updated Parkland formula is 2 ml into your total body surface area into weight, and this is the updated formula. And if at all there was a question which is asking about the fluid resuscitation, definitely apply this formula. For electrical burns, the formula is same. That is your formula is 4 ml into your TBSA into your weight. Right? Learn about pediatric. Okay, learn about that also, right? And if you want to have a clear explanation on burns, we have Friday power up sessions, which is under your NNL channel. If you click the live session, the last Friday power up session, which was taken by me, you can see that all the important topics I have been taken: burns, your blood transfusion complications, and I have talked about COPD, everything, the most important topic. In burn segment, I have talked about the important updation in the formula series, and you can watch that video. Okay, after this video, you can watch that video and expand your knowledge, right? Yes. So next question. An extramammary Paget's disease is commonly seen in which? Paget's disease. What is Paget's disease? Paget's disease means what? What is Paget's disease? Paget's disease is the what? Yes, now give me the answer. What is Paget's disease? It is a malignant intraepithelial condition of your nipple and areola. Remember, Paget's disease is a malignant intraepithelial condition which is attacking both your nipple and areola. Right. So this is termed as your NAC complex. That is your nipple areola complex. When the patient is going for, yes, now give me the answer. Yes, now give me the answer for this question. Extramammary Paget's disease is commonly seen in, like, when this Paget's disease is metastasis, where it will primarily attack. That is the question here. Now tell me the answer. What is the correct answer? It is a rare form of adenocarcinoma with apocrine gland involvement, right? As I said you. So now tell me, what is the answer? Extramammary Paget's disease. Paget's disease, first you have to have an understanding. It is a malignancy of your nipple and areola in combination. Like you can see the images are like, I have not put the images. Like you can see the images of Paget's disease in the net. You can easily see, right? So first and primary metastasis will be happening to the vulva only. Please be very clear. First and primary metastasis of your Paget's disease will be happening to the vulva. Labia majora and perineum is the most common site. So that will be the correct answer. Not vagina, not uterus, not cervix. Primarily, it will be attacking the vulva only. Right? Remember about this Paget's disease again. It may be asked in examination also. Right. So what kind of finding you can see? Initially, when you see a patient with Paget's disease, it will be looking like eczema only. It will be looking like eczema only. It will not be looking like a malignant condition. See, I had taken many previous sessions, okay, which is live sessions which are available in your YouTube, okay, which you can see, right? This is not the first session, right? I have taken many sessions. You can see in the English section and in the live section you can see, right? So first and foremost thing is, initially it will be looking like eczema only. Later, like you should not, the physician or telling that we should not misdiagnose it as an eczema because it is an actual malignant condition. So early diagnosis of this is very much important. But this Paget's disease will be primarily metastasis. Extramammary metastasis will be to your vulva. They are not asking mammary gland related metastasis, but they are asking about extramammary, which means apart from your breast and other organs, where this is done. It is done in the vulva, right? Next question. Which is the most common feeding regimen related to the complication followed by your total parental nutrition? Which is the most common feeding regime related complication following a total parental nutrition? Now tell me. I want your answers. Yes. Any answers? The questions are becoming tough. I feel like you feel like tough it is. Yes. Very good. Very good. The most common feeding regimen related complication followed by your total parental nutrition is hyperglycemia. The classical thing you have to remember, it is your hyperglycemia. Why? What are all the other things? The most common is hyperglycemia. What are all the other things you can see? For example, in your TPN, the TPN composition, okay, protein, fat, and carbohydrate. Okay, protein, fat, and carbohydrate, right? Protein is 20%. Ratio, like 20 is to 30 is to 50. 50 is the carbohydrate. When carbohydrate is this much increased, it will ultimately causes hyperglycemia, right? So first, the important NORCET centric points which you have to remember. In case of respiratory failure, yes, respiratory failure, what will be the quantity as well as the carbohydrate level? In case of respiratory failure, the carbohydrate has to be decreased. The carbohydrate has to be decreased. On the other hand, in case of renal failure, the carbohydrate has to be increased. The carbohydrate composition has to be increased. This is very, very important, right? So next, we're coming back to the feeding regimen related complication. Feeding regimen related complication. What are the other complication? So I'm writing here feeding regimen related complications, right? That is, first is hyperglycemia. Okay, hyperglycemia. Next is increase in body weight. See, the most common complication is your hyperglycemia. If there is a question, which is the early finding which you can see is your body weight, increase in body weight, right? So next is micronutrient deficiency. Especially phosphorus. We have studied already. But directly, if they're asking about TPN related complication, first and foremost thing is your earliest sign. If they're asking earliest sign is weight gain. That is the earliest sign. When we are specifically asking about TPN complication, you have to answer this. Here they are asking about TPN regime related complication. Here we are totally talking about the TPN complication. Earliest sign is weight gain. Here what micronutrient deficiency you can see? That is zinc. And we also have the catheter related complications. That is also very, very important, right? Catheter related complication also can happen. Most probably these TPN are administered through your central line only. So catheter related complications. What are the catheter related complications? Pneumothorax, infection, another all catheter related findings you can see in the catheter related complication. So we have to collect the sample from in case if you find the TPN infection is related to the catheter related complication, you have to collect the sample from the peripheries. Thanks for the wonderful compliment on my handwriting. Many people tell this. Okay, so whenever they're asking about catheter-related complications, sample collection, that you have to remember. In catheter-related complication, what you have to do, first is the catheter, sample from the catheter, okay, culture sample from the catheter opening, then from the peripheral sample also. 3 sample you have to collect when the TPN, the TPN complication you are expecting because of the catheter, then you have to do what? Catheter sampling, and catheter, like opening of the catheter also, you have to collect the culture sample, and you have to collect the what sample? You have to collect the peripheral sample as well, right? So these are all the important points you have to remember about your TPN. So hyperglycemia is the most common complication which is happening because of the feeding regime related complication. Along with that, you have to remember about body weight, micronutrient deficiency, specifically phosphorus. But in case of TPN related complication, you have to remember about zinc. And earliest sign in TPN complication, then it will be weight gain. Weight gain will be the primary factor which a nurse will be finding out it is because of TPN, right? So next question. Below are the images of different types of surgical knot. Match them with their corresponding names. So these kind of questions are very, very common. Now tell me what is the correct answer. See the options and everything. What is granny's knot? What is square knot? What is surgeon's knot? Yes. Very good, Suganti. Many people have commented about the concentration of the ratio of the TPN. Very good. I'm so proud of you. 1C. Very good, dear. Nagaraj, ultimate. 1C is correct. Next. Yes, for the next. Next. What about the second one? Quite fast. Make it fast. I want your answers. Square surgeon's knot has been found. Surgeon's knot is a complicated knot. You can remember, surgeon is very strict while putting this knot. So this is very, very tactical and it is like so much prominent. 2 is A. Obviously, it is easy because it is a 3 option, right? So 2 is your granny's knot and 3 is your square knot. How to easily identify this? I'll teach you how to easily identify this. For that, we will go into a picture. See, first is your half hitch. This is your half hitch. Okay, that is very, very easy and simple. And this is your crossed half hitch. Like slightly, if it is crossed, that we are terming it as crossed half hitch. On the other hand, reef or square knot. Square knot has another name, that is reef. Okay, reef or square knot is indicating same knot only. So what is reef or square knot? How to identify? If you see the crossing, okay, if you see the crossing here, it will be very much similar. It will be similar. It is similar. The important thing you have to notice, it is similar. The crossing will be similar. For example, black above and pink in the down. Same way black is above and pink is same. Like if you see this cross, it is same. The color coding is also same. But if you talk in granny's knot, it is quite complicated, where the crossing will be opposite. So here, if you see the crossing, it is totally opposite, right? Here pink is above and below it black is there. In the lower segment, if you see the knot, here again the black is above and the pink is down. Right? This is how you have to differentiate between the square or reef knot with the granny's knot. If the color coding is different, most of the time the color codings will be given, dear children. Just understood, in your reef or square root knot, the crossing will be similar. Whereas in your granny's knot, the crossing is going to be different. The crossing is going to be different, right? On the other hand, we have extra half hitch square knot. And this is your surgeon's knot. Surgeon's knot is very complicated because he is very concentratedly putting this. So you can remember in that way. Granny is quite confusing, but a reef or square knot is very compact. That is how you have to remember this. Granny is confused and creating crossing opposites, black and pink. But here in square root knot, the crossing is similar. Above is also similar, below is also similar. This is how you have to easily understand and you have to channelize this, right? So next is a young boy present with slowly enlarged painless swelling over the lateral aspect of the right eyebrow. Over the lateral aspect of the right eyebrow. Histopathology shows keratinized stratified squamous epithelium. which means keratinized stratified squamous epithelium, which means it is indicating your skin-like structure. So what is the diagnosis? Now tell me, what is the diagnosis if you find a patient who is having an enlarged painless swelling over the lateral aspect of the right eyebrow, and histopathology shows keratinized squamous epithelium with hair follicles? What is the diagnosis? Lacrimal sac mucosally. Lacrimal sac mucosally is involving keratinized epithelium. Be very clear. See, the correct answer is your choristroma, not your D. The correct answer is choristroma. I will tell you why choristroma. See, choristroma, this is your choristroma. See, this is the squamous, keratinized squamous epithelium, and this is a painless swelling, and it can acquire congenital or not, and it will be growing also. This is your hematoma. This is your hematoma. Okay. This is your hematoma, and this is your lacrimal sac mucosally. Yes. Lacrimal sac mucosally. Very good, very good, very good, Gayatri, very good, Suman. Please be with me. We have some of the important questions left. So please be with me. Don't take a break. Right? We will be going quite fast so that we can complete it soon. Right? So it is a lacrimal sac mucosally. Right? Be very clear. This is your, and adenoma, you know, adenoma is a non-malignant granular origin kind of non-malignant form of cell accumulation. You know that adenoma of your breast, right? So that is very different. So this is your hematoma. Image is very, very important. This is your choristroma. This is your choristroma. This is your hematoma, and this is your lacrimal sac mucosally. This is very, very important to note. Next, we will go to the next question. A 25 years old man presented to the emergency department. He has flat white patches in his oral cavity, and unusual bleeding in the mouth, and a biopsy is done, and end-stage oral cavity cancer is diagnosed. End-stage oral cavity cancer is diagnosed. Which of the following is one of the biggest risk factor for developing oral cancer? Again, see, hematoma is an abnormal arrangement of the native tissue. It is an abnormal arrangement. Native tissue, like wherever the skin growth is possible, hematoma can form. Like in whatever area we have a keratinized epithelium, it can follow, it can do. Right? That is your hematoma. This is also painless. Right? Yes, coming back to that. Yes. So human papilloma virus, why we are concluding it is an human papilloma virus? It is indicating your oral cavity cancer. So oral cavity cancer is very common and high risk for the patient with human papilloma virus infection. Right. Yes. The next question. What triad is characterized by abdominal pain, fever, and jaundice? What triad is characterized by abdominal pain, fever, and jaundice? What triad is characterized by abdominal pain, fever, and jaundice? Any answers? What triad is indicating the abdominal pain, fever, and jaundice? Very good. It is your Charcot triad. Charcot triad is done in case of what condition? It is in case of your acute cholangitis, right? In case of your acute cholangitis. Right. Acute cholangitis means the biliary tree, infection in the biliary tree. Infection in biliary tree. Infection in the biliary tree. Right. So what is the other triads? Like we will discuss about the other triads also, which can possibly asked in examination. I have a quick review. You can also take the screenshot. Charcot's triad is right abdominal quadrant, abdominal pain, and fever, jaundice, which is talking about acute cholangitis. Next is your Renal triad. Renal triad. Renal triad is also in case of your cholangitis, that is severe suppurative form of infection of your biliary tree, is indicating your severe suppurative cholangitis. That is indicating your Charcot's triad plus hypotension plus altered sensorium. Right. Charcot's triad plus hypotension plus altered sensorium. Next is your Sainz triad. It is indicating the patient is having gallstone, that is cholelithiasis, plus hiatal hernia. Okay. Gallstone, hiatal hernia, colonic diverticulitis, which is Sainz triad is seen in case of your coincidental association, right? Sainz triad, which can be seen coincidental association with various conditions like gallstones plus hiatal hernia plus colonic diverticulosis. Next is Witchow's triad, which is very commonly asked and previously asked question also, which is indicating endothelial injury, hypercoagulability plus stasis, which is seen in case of your thrombosis formation, either in DVT or in case of your pulmonary embolism. Next, we have Whippley's triad. Whippley's triad, that is hypoglycemic symptoms plus low plasma glucose plus relief with glucose. Right. This is involved in insulinoma diagnosis. Beck's triad, you all know hypotension, muffled heart sound, and rise to JVP, which is seen in case of your cardiac tamponade. Next is your regular triad, that is your pneumoplia, ectopic gallstone plus small bowel obstruction. And gallstone, this is seen in case of your gallstone ileus. So next is your Meniere's triad. Meniere's triad is seen in case of your vertigo, tinnitus, sensorineural hearing, and sensorineural hearing loss. Vertigo, tinnitus, and sensorineural hearing loss, which is seen in Meniere's disease. Your Huntington triad, interstitial keratitis, Huntington teeth, and eighth nerve deafness. Eighth nerve deafness, which is seen in case of your congenital syphilis. They can be possibly asking these questions. So that's why. And next is your Samter's triad. Samter's triad is also an repeated question. And I'm expecting these questions. Asthma plus nasal polyposis plus aspirin sensitivity. If the patient is having, we are telling the patient is a case of Samter's triad. Next is aspirin exacerbated respiratory disease. Okay, we are identifying with the help of Samter's triad. Addison's triad, hyperpigmentation, hypotension, and hyponatremia or hyperkalemia. That is seen in case of your adrenal insufficiency. Next, we have Meckel's triad, abdominal pain. Meckel's triad is seen in case of abdominal pain, rectal bleeding plus palpable mass. If the patient is having abdominal pain, rectal bleeding, and palpable mass, that is talking about your Meckel's triad, that is talking about your Meckel's diverticulum, as the name implies. So classical appendicitis triad. What are the classical appendicitis triad? So this is also very important to learn because these can also be asked. Pain, periumbilical to right lower quadrant pain plus vomiting plus fever. If the patient is having, we are telling it is a classic appendicitis triad. Next is, it is seen in appendicitis, as you all know. Paroxysmal triad, when the patient is having headache, palpitation plus sweating, pheochromocytoma. It is seen in pheochromocytoma. Again, I'm expecting this to be in your question paper. Next is your East-Menger's triad. East-Menger's triad, which is seen in case of East-Menger's syndrome, pulmonary hypertension, cyanosis plus your right ventricular hypertrophy. Pulmonary hypertension plus cyanosis plus your right ventricular hypertrophy. Next, we have your Boerhaave triad. That is your Boerhaave triad or your macular triad. Any name they can ask you, Boerhaave triad or your macular triad. That is seen in case of your esophageal rupture, where the patient will be having, excuse me, vomiting, chest pain, and subcutaneous emphysema. Right? Without any delay, we will go to the next question. For which procedure is number 11 blade is primarily used? Answer me. For which procedure is number 11 blade is primarily used. Number 11 blade, now you have to be very clear like how the blade looks. Right. This is your 11 blade. Right. So for which procedures among these options? Yes, rectal bleeding will be there. Abdominal pain we are telling. We are not telling about pain with. Yes. Abdominal incision. Do we use number 11 for abdominal incision? Be very clear. Like you should have a wide thinking to answer this question. Open or skin incision. Open or skin incision, we are using 10. Okay, like I'll show this image, you will be very clear. See, 11 we are using for arteriotomy or stab incision. Very sharp one. 11 is a very sharp kind of blade which we are using in stab incision and arteriotomy. Right. And when we talk about blade 10, for skin incision, for minor skin incision, we are using this blade 10. Next, for 15, if you talk about 15, which is given in the option, for fine plastic or pediatric work, we are using blade 15. Right. Very good, Neha. Very good, Neha. Very good. Right. For fine plastic or pediatric incision, we are using blade number 15. 20, 22, these are used for large abdominal incision. As you can see, the presentation of the blade is also very large, and it is stating that it is used for large abdominal surgeries. So always remember 11 is the one among the given options. 11 is the one which is used for 11 is primarily used for arteriotomy and minor plastic surgery related incisions. Right? Minor plastic surgery related incisions. So next we have the next question. What is the diagnosis of a neonate who is brought to hospital with complication of forceful vomiting that is not accompanied by bile after feeding? Forceful vomiting, that is indicating the patient is having projectile vomiting. Projectile vomiting. Forceful vomiting, which is indicating the patient is having a projectile vomiting. Right? Who is brought to the hospital with the complaints of forceful vomiting and not accompanied by non-bilious vomiting. So what is the answer? It is very good. It is your congenital hypertrophic pyloric stenosis. The most important classical feature you should remember is, remember in ultrasound, the findings is different, but in a barium study, in a barium swallow, you can see what is congenital hypertrophic pyloric stenosis. Congenital hypertrophic pyloric stenosis states that it is a condition where there is a proximal narrowing. Okay, proximal narrowing of the duodenum. Proximal narrowing of the duodenum. Right. When you see, so this is the conveying to the duodenum, right? This is conveying to your duodenum. And here there will be narrowing that is termed as your congenital pyloric stenosis. The important sign, the most common sign which is asked in your examination is you have to remember string sign. It is a string sign you have to remember for this patient with congenital pyloric stenosis. Yes, double track sign, sing sign. Again, teeth sign, shoulder sign, beak sign. These are all double or triple track sign. These are all seen in case of your barium study. The most common sign which is tested in your examination will be string sign. You should be very, very clear about it. Right. So in jejunal atresia, you will be seeing what? You will be seeing triple bubble sign. You will be seeing triple bubble sign. So on X-rays also, I have taken a special session. You can also watch the X-ray lectures also. In duodenal atresia, you can see double bubble sign. You can see double bubble sign. Right? So this is very, very important. Duodenal, double, you remember. Jejunal, JT, triple, you have to remember. Here you have string sign. Right? So the next question. So a 69 years old man comes to the physician because of 2-day history of redness, swelling and pain in the right leg with fever, chills and nausea. He reports seeing liquid oozing from the affected area on his right leg. His temperature is 38 degrees Celsius. His pulse is 106. and his blood pressure is 152 out of 94. Examination of the right lower leg shows a large area of erythema with poorly demarcated border. Poor demarcations are seen in case of your wet gangrene and cellulitis as well. And purulent drainage. The area is fluctuant and warm and tender to touch. In addition to incision, drainage and taking culture from the wound. Which of the following is most appropriate? It is indicating a case of severely infected cellulitis. So obviously the primary management is what? C is the management. C is the management. Why you people are answering C? C is not the correct answer. What is the most appropriate next step? See, primarily IV vancomycin, which is an empirical antibiotic, okay, which is an empirical antibiotic, which has MRSA coverage as well. That will be the primary intervention. Next step in the management. Then only they will be going for surgical debridement. Oral clindamycin is not effective. Oral dicloxazine is not effective because the patient is going for severe condition, right? And they have purulent drainage as well. First is administer. Yes, very good, Siddesh. Very good, Siddesh. Very good. Very good, Bhavana. Very good, Suman. Very good, Ankot. Very good. Very good, Trishuta. Very good, Sumat. So listen, surgical debridement is a secondary option. Primary is to give the intravenous vancomycin, right? Next question. Only we have few questions. We will go back. Mild cellulitis, non-purulent, non-systemic, we will go for oral. Moderate also IV cefazolin and clindamycin. But purulent cellulitis, we have to go IV vancomycin with MRSA coverage. Rapid progression, bulle, crepitus, hemodynamic instability. Then we will go for surgical debridement. Right? So the next question. A known case of papillary carcinoma of the right breast had some of your hospital had come to your hospital for surgery. A modified radial mastectomy procedure has been done. And on the second postoperative day, the patient present with the following finding. Okay, shown in the figure below, which nerve would have been damaged during this operative procedure? So here, what is the sign you are seeing? That is your winging of scapula. So winging of scapula is seen in which condition? Now tell me, winging of scapula is seen in which condition? So the patient is done with radial mastectomy. Post-radial mastectomy, we are expecting the patient may have an injury to the long thoracic nerve. The patient may have an injury to the long thoracic nerve, which is arising from your C5, C6, and C7. And if this long thoracic nerve is affected, okay, which is supplying to your serratus muscle, right, which is supplying to your serratus muscle, when this particular nerve is affected because of the radial mastectomy approach, there is possible chances that this can be affected. Very good, winging scapula, very good, Simon. But what particular nerve damage is leading to winging scapula? That is the question here. So what particular nerve damage is leading to winging scapula? It is your long thoracic nerve, right? Which is supplying the nerve supply is done to the serratus anterior muscle. So here the long thoracic nerve effect can lead to this winging of scapula, but because of this radial mastectomy approach, there is high chance that long thoracic nerve is the most commonly damaged part. So which can lead to what? Winging of the scapula. So the next question, again, please have this a look. A long thoracic nerve, serratus anterior muscle, it is supplying, and winging of the scapula you can see. So spinal accessory nerve, which is supplying trapezius, lateral winging and shoulder drop also you can see when the mastectomy approach. So always preserved during modified mastectomy to prevent postoperative morbidity. So primarily these nerve damages are always preserved in order to avoid this kind of morbidity. So next question. A 36 years old man present to the hospital after sustaining a severe motorbike collision. On examination, the patient is hemodynamically stable and alert. Initially, the patient is hemodynamically stable and alert. See the question. See the question carefully. Okay. A 36 years old man present to the hospital after sustained severe motorbike collision. On examination, the patient is hemodynamically stable and alert. X-ray shows multiple fracture. X-ray is showing multiple fracture. The whole body CT shows a bilateral pulmonary contusion with a small hemothorax as well, a renal contusion as well, and a multiple pelvic fracture. See, it's a very serious condition. So progressively, the patient becomes hemodynamically unstable. Initially, the patient was stable, and later he is becoming unstable. 3 units of packed erythrocytes are given together with 1 gram of tranexamic acid and 100 ml hydroxyethyl starch. So laboratory parameter analysis from the blood sample drawn at the admission confirms the patient is having coagulopathy associated with metabolic acidosis. See, the last point of your answers, last point of your question always have the important tricky words. The last points of your answer will always have tricky points. Neha, please, Neha, please understand, like, it is confirming the patient is becoming hemodynamically unstable and he is having coagulopathy and metabolic acidosis. Whether you people have heard about this lethal triad? Lethal triad. The lethal triad is the combination of your coagulopathy, metabolic acidosis, along with that, the patient will also have hyperthermia. Sorry, the patient will be having hypothermia. This is called as a lethal triad in your trauma cases. Lethal triad is composed of 3 cases: coagulopathy, metabolic acidosis, and hypothermia. So this is very, very important. This is assessed in case of trauma management. See, the patient is becoming so much unstable. Okay. What is the correct answer? Yes. Neha, yes. Neha, first is to prepare the patient for a damage control surgery. See, these questions and all, if you're preparing only, you can able to answer. If you're not preparing, you cannot answer these questions. If you find such questions are so tactical and so critical, please avoid these questions. Don't get negative mark. Don't fetch negative mark. A is the correct answer. Please give a big round of applause to Neha. First, remember about the lethal triad: coagulopathy, metabolic acidosis, and hypothermia. These are the primary criteria for the patient to be shifted to the damage control surgery. First, we will do the damage control surgery and we will try to stabilize the patient. See, a patient should be hemodynamically stable for any operative procedure, hence aggressive resuscitation. No, resuscitation is not working. The patient become unstable. We have done an effective resuscitation of administering tranexamic acid and 100 ml of hydroxyethyl starch, but the patient is not recovering. Again, if you're going to do some aggressive resuscitation, no. So coagulopathy has to be corrected as a part of resuscitation, and then operative control and hemorrhage and contamination is performed. No. Coagulopathy is a part that is involved in promoting the patient to or directing the patient to the damage control surgery. If hemodynamically stability is achieved, conservative management, no. See, let us be very clear. First is damage control surgery. What are the criteria the patient should be going for damage control surgery? Right? If you're not studying for the questions, if you're not studying like in surgery, under surgery, if you're not studying about damage control surgery or early total care, you cannot answer these questions. Don't take risk. If you're studied, confidently get into it. See, we have seen acidosis and coagulopathy in the patient condition. Both acidosis and coagulopathy we have seen in the condition. But hypothermia was not classically written. But if this hypothermia, acidosis, and coagulopathy all together is called as lethal triad, that also you have to remember Can be asked in your examination. Question point. So what are all the criteria which I'm selecting if the patient has to go for a lethal, has to go for a damage control surgery? Damage control surgery is to maintain the stability of the patient. You have to remove all the contamination, basic stability you are doing, then you're going for the actual surgery, right? So hypothermia, the patient will be having less than 34 degrees Celsius, pH, acidosis the patient is going for, and coagulopathy, there the patient case of metabolic acidosis. Coagulopathy is present, severe bleeding is present, and serum lactate is greater than 5 millimole per liter. It's indicating severe form of infection. So BP is less than 70 mm of Hg, and transfusion is approaching 15 units. We want 15 units of blood transfusion, which has to be done to stabilize the patient, right? Approaching 15 units of blood transfusion. So we are prominently indicating the patient for damage control surgery. So injury severity score is also showing greater than 36, and vasoactive inotropic support is necessary for the patient, and overall patient status is critically ill, unstable, and physiologically exhausted. At that time, the primary thing which you have to do is a damage control surgery. Next is early total care. See, first they will do like early total care. When the patient is proceeding with that, the stability is not achieved, then we will be going for damage control surgery only. In early total care, what are you seeing? The patient will be having normothermia, normal pH, and coagulopathy will be absent. The patient's serum lactate will be normal, stable hemodynamics, and the patient will be having no transfusion necessity, and injury severity score will be present, and the patient will be stable. Vasoactive medications is not required. Physiological stable and can tolerate definitive surgery. For those patients, we will be giving early total care and we will be going for the surgery, right? Definitive surgery. Here, when the patient is simply, the coagulation status is not good, the patient is going for hypothermia, metabolic acidosis, and the serum lactate level, everything you're seeing, it is declining completely. So, primarily, you have to, yes, the question is very long. We are not expecting such questions, but to have a touch, I have put this question, right? So, what will happen? Obviously, you have to do a damage control surgery only. In early totality care, if the patient is proceeding with these following symptoms, we will be going for damage control surgery rather than going for definitive surgery. That is the important point you have to remember. Next question. A patient after heavy drinking of alcohol present with multiple episodes of vomiting and hematemesis. What is the most likely diagnosis? Yes, the patient who is having heavy alcohol drinking. Now you have to tell me the answer. Tell me in the comment box what is the answer. This is a very easy question only, so you can easily answer. Very good. It is your Mallory-Weiss syndrome. That is your Mallory-Weiss syndrome. What is Mallory-Weiss syndrome? That is your longitudinal mucosal tear. Longitudinal mucosal tear at the gastroesophageal junction. At the gastroesophageal junction. Right? Esophageal carcinoma? No. See, the patient is having vomiting with hematemesis after multiple episodes of your after drinking of a heavy alcohol, which is indicating longitude. Like frequent retching and vomiting can lead to hematemesis because of the excessive staining. It can go to it can proceed the patient to go for this mucosal tear of the gastroesophageal junction. Esophageal carcinoma, you will not be seeing this presenting symptoms. Achalasia cardia. What is achalasia cardia? That is the narrowing or the impaired function of your lower esophageal sphincter. LES is your lower esophageal sphincter. What does it mean by your Bory-Have syndrome? That is your esophageal perforation. That is your esophageal perforation. Here you will be having retching, vomiting, but Here, the patient will be having a sudden and severe chest pain. The patient will be having a sudden and severe chest pain. That is very important, right? Yes. The next question. Only 4 questions are left. Yes. A 34 years old man presented to the surgical emergency room with a high speed road traffic injury sustained 4 hours earlier, has a severe shortness of breath at the time of presentation. So on examination, his blood pressure is 90-60 mm of Hg and his heart rate is 100 beats per minute with the oxygen saturation of 85% at room air. The breath sounds are reduced on the left side and his jugular venous pressure is also elevated. The chest x-ray is done. Which is shown in the picture? Okay. And which of the following statement is correct? We are suspecting the patient is a case of tension pneumothorax. We are suspecting the patient is a case of tension pneumothorax. So obviously, the best investigation for the diagnosis is a non-contrast CT, but primarily emergency management of your tension pneumothorax is needle thoracentesis. Location updated is 5th intercostal space. Okay, we should not wait for the here what you have to remember is if the needle thoracentesis related options are given, you have to click that only here, but they have not talked about any form of intervention. So primary diagnosis will be done with the help of the best method of diagnosing is the non-contrast CT. But initially, we won't wait for the diagnosis. If you see the following symptoms, we will go for emergency needle thoracentesis, right? So remember about this. Next, we will go to the next question. Identify the lesion shown below. Yes. Needle decompression. Very good. Triangle of safety. Very good. Very good, Shreyansh. Yes, tell me. The next. Identify the lesion shown below. Obviously, you can see it is a wet gangrene. Right? It is not a dry gangrene. It is not a force bite. It is not a enhance. The next question. Which instrument is depicted in the image? Which instrument is depicted? Yes, very good, Suman. Which instrument is depicted in the image? Answer me. Only 2 more questions. Which instrument is depicted in the image? It is Alice forceps. Alice forceps or toothed forceps. This is your plain dissecting forceps. This is your plain dissecting forceps for if I want to do a non-harming or I should not injure that particular area, but I want to visualize the tissue. In surgical cases, I will be using this plain dissecting forceps. Always remember, plain dissecting forceps does not have any tooth. Plain dissecting forceps does not have any tooth. A 32 years old male present to the emergency department with burns injury 2 hours ago. Examination revealed second-degree burns covering 20% of the total body surface area. The patient is immediately resuscitated with fluids. Which of the following fluid is most commonly used? A very, very common question in previous cases also. Yes. In previous cases also, I have discussed about this. Ringer lactate will be your correct answer. Ringer lactate will be your correct answer. Yes, we have came to the end of the session. So for the students who were actively with me, I'm thanking you so much from the bottom of my heart. All the very best for your mains examination and follow my page. Follow my page, Nursing with Priya Balan. Whenever you have any form of doubts, you can ask me in this Instagram page, Nursing with Priya Balan. Okay. When you have when you need any form of personalized guidance at that time also, you can contact me directly through a message or through a call. You can directly connect with me. So that's why I'm informing about this. And before your prelims examination, before your mains examination, I'll be releasing some important strategies for you people so that you can also make use of those strategies. And please add in the comment box separately, like what was your experience about the session, whether the session was useful for you, how it was. You have to see whether I want to do any modification or changes in the style. What is your, yes, how many questions you have to attempt in your mains examination. See, the safest attempt is 120 MCQ. Okay, always remember greater than 120 MCQ, you will be safe. First, you have to analyze the paper. If the paper is tough, it is going to be tough for everyone. If it is going to be moderate, it is going to be moderate for everyone. If it is going to be easy, it is going to be easy for everyone. But things vary, like the student who have prepared for the examination and the student who have not prepared. So this is a varying factor, right? So the safe attempt will be greater than 120 MCQ to get a merit list, right? So definitely do attempt of greater than 120 MCQs. In some experts or even telling you have to attempt 130 plus, because the competition is heavy. So definitely you have to give this good number of attempt, right? Do it definitely. And let's see how it is going. Yes, obviously accuracy is more important than numbers, but if you are attempting 4 questions, dear children, I'm telling 1, 2, 3, 4. Okay. If you're attempting 4 questions, like in some cases where you cannot able to attempt more number of questions, in that cases, what you have to do is you can take a calculated risk. For example, if you can able to reject 2 distractors, if you can able to reject 2 distractors, you are stuck up with 1 or 2 you are stuck up in 2 distractors. You are stuck up in 2 correct answers, like either A, B, C, D. C and D, you are definitely telling it is wrong. The answer is between A and B, so you can give an attempt. If you're taking risk in 4 questions, like where the distractors is quite tricky, you're attempting that 3 and 4 are wrong, but 1 and 2 are correct. That time you can fetch mark. But you should not use this strategy in all aspects, right? Okay, with this, all the very best for your examination, mains examination. With the same in to go for your examination, I'll meet you all in Thursday on pharmacology session. Thanks for watching. All the very best for your mains examination.